Women's Health and Adult Social Care Overview and Scrutiny Committee. Do we have apologies for absence? Councillor Galvin?
Yes, Chair, Councillor Barrett.
Thank you. Councillor Scott?
Thank you, Chair. I'm subbing for Councillor Amadishi as there were too many...
Conflicts of interest.
That's exactly
Thank you very much.
Thank you.
Thank you. Councillor Spring?
Mr Chairman, subbing for Councillor Perfect.
Thank you very much. I have no urgent business to announce. Are there any disclosable pecuniary interests or other significant interests or whipping from members this evening? Nothing at all. Thank you. Members, I've had a request to move item 8 to the beginning as one of the attendees needs to get away to help with a family member. So I will be taking item 8 first, and we will then follow the agenda as printed. Is that agreed, members? Agreed. Thank you. We have a heavy agenda this evening, so please can I remind you all to keep introductions to a bare minimum, those in the audience too. Members have read the paper, so please use the introduction just to update members on anything not included in your papers or to draw attention to the very key points, please. We now go to item 8, which is we're establishing a group between... Sorry? I've agreed the minutes. Chris is not on here. Members, do you agree the minutes? Thank you very much. Thank you. We're going to item 8, and it's MFT. It's establishing a group between MFT and DGT, and it's over to Siobhan and John. Thank you.
Thank you very much, everyone. Hopefully my voice will hold out. Thank you very much for bringing the agenda item. John Galston, Chair of the Trust.
I'm Siobhan Cannon, Chief Executive Medway MFT.
Apologies from John Wade for tonight. Just 3 or 4 things, just as way of introduction. The first thing is that both boards are still absolutely committed to a group model. This is just how we evolve into a group. We have our next board-to-board actually scheduled for the 2nd of April. At that meeting, we'll be considering a paper to establish a committee in common, to appoint a programme director, to help us with the programme for the first year or 2, and also to receive a paper from John on digital opportunities to work together. Both organisations will be moving to having their own chief executive from the 1st of April. Medway Foundation Trust, we have commenced this week with the process of recruiting a substantive chief exec, and Siobhan is with us until we get to that point.
Thank you, John. Members. Councillor Campbell.
Thank you, Chair. John, I'm so sorry that your voice is so strained, and we're all going to be posing lots of questions to you. Okay, so I've got 2 questions for you. Right from the start, when Jonathan took over Medway Foundation Trust, it was always said that it was about greater collaboration, closer working together, and then there was talk of sort of being in partnership, but not a merged setup and things like that. So looking at this report, the review that you conducted and the 3 organizational options that you came up with, I mean, I just genuinely don't understand the differences. It's what the actual, why, I'm just trying to weigh up, why was this? I mean, they all seem to be about greater collaboration anyway. So I'm interested in understanding your reasoning behind that. And the second thing I'm really curious about is this process of decision where it's been decided that you will now have 2 separate CEOs. Because if you remember, when it was first decided that Jonathan would be CEO for both trusts, I think we as a committee had raised concerns about that. We had raised concerns about capacity and sort of continuity of service and things like that. And we were assured that it was all in hand. Actually, this was a move towards better, closer, consistent working. But now that's changed, and now you've decided you want 2 separate CEOs. So I'm really interested in understanding what your reasoning is for these 2 choices.
Yes, so the principles of what we want to do are the same. It's the sort of how we get there. And I think one of the key things that has led to the change to going back to having 2 chief execs while still doing the collaboration is the fact that over the Christmas period, it became clear that Kent and Medway as a system had a £180 million financial problem in terms of this year. Quite a bit of that problem lands with Medway Foundation Trust to a lesser extent, but there's still a problem with finances are adrift also at Dartford. And I think looking at the work that we have to do over the next 12 months in order to address that financial challenge, A, within Medway, B, within Dartford, and C, across the Kent and Medway system. And most of that deficit is with the financial challenges with the acute hospitals. That it really builds on some of the concerns that you and others, including your lead, including Vince and Teresa, have raised in terms of, in order to do that, that's asking a lot of a new chief executive whilst we're trying to form a group. And therefore, we feel that actually you need two chief executives to marshal through what we need to do in the short term. Now, assuming that we are able to have a plan that's robust for 26, 27 and show that we can deliver that plan, the same applies to Dartford. Then in a year or two, we will come back to the issue of what's the right time to move to one chair and one chief executive. So in effect, we've had an added financial problem, and we've also listened to what yourselves and others have said also about that.
That's a very interesting take. You could be a politician, you know. We have listened and we have changed. Impressive. Were these new things that came to light, the pressures? I'm just wondering, because we did raise concerns, didn't we? We did flag all these things, and it did seem like a high-risk strategy to have one chief exec shared across two trusts. What you're saying is you kind of did decide it was too much for one person. So, I mean, there's no satisfaction in saying we told you so, but the point is a lot of movement seems to have happened at such a senior position, causing so much, you know, disruption, because now you're going to have to recruit a new person. I'm just not sure that decision-making was robust or well thought out or future-proof for that matter. I still have the question I asked previously about the three options and what the differences were between them.
So the difference in the three options is one was just carrying on as we are. But one of the things that I think we're clear on in terms of as we do that, we have had collaboration to date. Some of that collaboration hasn't gone as well as it should have. ENT is the prime example of that. And therefore, actually, we need much more formal structures in working together to ensure that there are various services that would like to collaborate. Pediatrics, urology are two examples. But actually, we need a more formal structure to enable that to happen in a better way. And actually, some of the enablers like digital is a good example of how do we work when we've got services that we want to make more joined up, but having two separate IT systems in effect, even though we're using the same partner. How do we do that in a better way to make it easier for the administration side from our staff, but easier for our clinicians? I don't know if you want to come in.
Really keen, as are we. Okay, I think it's on now. Sorry. So we're really keen to maintain that momentum. It doesn't, you know, just because we haven't joined at with the joint chief exec, joint chair, doesn't mean that clinical teams won't go ahead and do that. So we're very much about doing that. But what we do need to do are the infrastructure behind that, which will be the digital and the governance bit. We need to get those right. The ask is a lot within this year. We have a very big challenge within the organisation. We need to focus on delivering that. So we have safe, sustainable care at Medway and at Dartford, and we didn't want to compromise that.
So the options were basically carry on, which we feel in order to collaborate well, we need to, that's why we've dismissed that as an option. And we've also dismissed, you know, we're not interested in merging as organisations because we feel that would be a distraction.
Councillor Wilding.
On the same theme, really, I think I've been quite vocal that I wasn't very keen on a joint CEO. I can't understand, as Medway in particular, but both hospitals have their problems, if one CEO for each hospital can't solve the problems, how one for both is going to be any better with twice the workload. But reading this report, I thought, oh, well, at least you're now accepting the two separate CEOs. But in your answer just now, you, whatever the phrase was, you meant that's for now, but moving forward, we will end up with one CEO. Shall I pause there? You look like you want to come in.
So it really is a question of the advantage of the option that we've changed, that we're going through, is we work at our pace. We need to get things right first time, obviously, in the future in terms of the timing of things. But I think one of the things to stress is actually there have been successes in terms of the last few months, and in terms of, with John as the chief exec, with Siobhan and colleagues, in terms of waiting times for elective care, cancer care, and urgent emergency care, our improvement in the last 3 months is the second best level of improvement of any trust in the country. Now, it's up to us to ensure that we carry on with that. So, you know, we've got to get the finances right to fit around the rest.
John, do you want to clarify that when you say you're second best in improvement in what? Like in everything you're doing in the hospital across the country? Is that what you're saying?
No, just in terms of emergency care metrics, cancer metrics, and waiting times for elective. So we were in a pretty bad state on those a year ago. So, you know, there has been work that has been done by Siobhan and the exec team working with the divisions where we've made good progress. We just got to get the money right.
Improvement does depend on the starting point. If you're starting from a very bad position, it's easier to make good improvements than if you're in a good place already. I think Mark Devlin first wanted to merge two hospitals 15, 20 years ago. I can't remember how long. Since then, every chief executive officer has not seen that as the way forward. And now we're back where we are, where you want to go. When you interview for your next CEO, will that be on condition that they agree with the joining of the two hospitals as a good idea? Will they be independent? Will they be able to have a fresh set of eyes? Or will it be people that agree with your model, or you don't think they will have the right attitude and will not be considered?
There's a lot in that question. We have no interest in merging as organisations at this point.
But if you move to one CEO, that's...
But at this point, we are appointing two CEOs. Those CEOs will be in place, hopefully, for some time. So, you know, when we come back in 2 or 3 years' time, then we can start to look at the following phases that happen. But certainly we're looking for someone who agrees in terms of with the philosophy, with the vision that actually they agree with the benefits of Medway and Dartford working together as a group. The big difference between today and 15 years ago, there are lots of different group models in the NHS. And in many of them, if you look at one of the most successful one in the West Midlands, they have 4 trusts in that group. They are 4 independent organisations. Those trusts have no intention of merging. So it's you can do things in a different way. You can stay independent as organisations and then maximise the benefit of working together where it makes sense to improve patient care and improve the use of resources.
May I continue? Yeah. There are other hospitals in Kent that we could, or hopefully, and we do work with. If John Wade hadn't been the interim, who was, you know, not the chair, sorry, the CEO of Darrant Valley, so that would obviously be his first choice of combining, in whatever phrase you want to use. If we got a CEO that was from Maidstone Hospital or et cetera, you could go around all the hospitals, they may see combining with them being better. Why have we ended up between us and Darrant Valley?
Because it's not about the people, it's about the populations that we serve and the synergies that we have between our populations and the Dartford Gratian and Swanley populations. This is about what's best fits. We already have quite a lot of collaboration between the two organisations. So there is, and if we go back to the original report, we went through, I think the first time we were here, the reasons for why we thought as two organisations, actually we should work together more closely rather than work with. That's not to say on certain things, there are certain things we should do once in Kent and Medway, you know, for more specialised services to get economies of scale. For example, we have one pathology service across all the hospitals. So there are things where of course we will collaborate with the other hospitals. Cancer is a good example where we collaborate with MTW. But what we're talking about is a deeper collaboration, helping some of the services which both of us have, which are not that big. And where we each have a few clinicians, join the two up, they can work much more effectively. The subspecialisation of gastroenterology is a really good example, liver medicine being an example of that, where the clinicians want to work together. So this is about working together to serve the populations, and in terms of how we can do that in a practical way without people having to travel up and down between the two hospitals.
Yeah, it's about kind of making sure that, John referenced it there, around those experts, making sure that we are providing a really good place for our junior staff to learn and train. And we can do that across two sites as well, because we'll have subspecialties within each area. But the benefit for the patient is about being seen in the right place the first time. So that's really important. That's one of the drivers for us.
I'm not convinced, but I'm sure the chair wants to move on.
Thank you, Councillor Waddy. Thank you. Councillor Goldwyn.
Thank you, Chair. I've been a councillor this time in Medway for 15 years now, and I've totally lost count over that period of time of the changes in CEO and recovery plans of Medway Hospital. Whilst I fully admit you're probably in a much better place than you were 10 years ago, there's still a lot that needs putting right. And I've had a personal experience of that over the last 3 years, which we won't go into now. What worries me is you're spending an enormous amount of time, senior management time, faffing around with changes and not getting on to the real job. And the real job, as far as I'm concerned, is to provide excellent care for Medway's residents. In the last few years, we've seen the loss of services from Medway Hospital to other hospitals on the grounds that you want to create centres of excellence. And I get it that you need a certain level of population for some more trickier treatment. I mean, 600,000 comes to mind for some procedures. But, you know, what are the centres of excellence that in Medway Hospital? I can't, you know, I asked that question before a couple of years ago, and I didn't get a good answer. So personally, I'd far rather you concentrated on good quality care at Medway Hospital than trying to sort of alter structures and combining things. That doesn't, that's a peripheral thing. There is too much, as far as I can see, going wrong in the hospital that needs total 100% focus from senior management, and that's not happening.
Okay, so I absolutely agree with you that we need to be focusing on patient care, quality of care, and patient experience and outcomes. That's absolutely our focus. And that's why we've been working hard to make sure our patients aren't waiting too long, but also when they're within our care, that we're delivering good care. So this year, in the last year, we've been relooking at our governance process to see how we're identifying what we're learning from. Are we implementing that change? Are we evaluating that? We still have a way to go. And one of the biggest things that I think we know and we recognise, and we've been here and talked about before, is the culture. Because until we change the culture, we're not going to sustain that change. We do have areas of excellence at Medway. So our urology cancer service is well recognised. Our paediatric service, our maternal medicine service is held in high esteem as well. So we have a number of areas where we are already recognised as centres of excellence, which is great because what we want to do is work across the system. And if we're providing that centres of excellence, people will come to us as well. But you're absolutely right. We do have to get the basics right as well. There's no reason why we can't do that at the same time. And that's the challenge. But what we do need to make sure is that we sustain that change. We also have to work within a financial envelope, so we need to be doing that efficiently, and that's the challenge as well. That's why we need to be working with our partners in the community, mental health trust, primary care, the other acute services, so that, because all of us have got to make changes. This is transformation. This isn't tweaking around. This is transformation of care to enable our patients to get their pathways quickly and efficiently.
Just come back, Chair, I'm not convinced, but I'd like you to prove me wrong.
Well,
Thank you,
the
Councillor.
most important thing is, excuse me, is the cultural transformation programme. That hasn't been done before. We haven't tried to address the cultural problems that have been in the hospital for the last 15 years. We're doing that now.
Councillor Cook.
Yeah, thank you. I think just to draw on those questions. So I personally, really appreciate collaboration. I know we all do. I can see that you've got some huge problems, as you've said, financially, and the kind of examples that have been given that you've been working on and you're continuing to work on, and you've identified that there's strength in working together, and I can really see that, and that's coming across. I think the bit that makes it difficult for me, as somebody that isn't in it every day and is reading, and thank you for the report and taking from that, it's the what happens next and when's it going to happen, what and how, and the kind of logistics of, and therefore will it look different for Medway. And so I can absolutely understand you've decided perhaps to slow the pace, it might be, is what I'm reading here, to kind of go separately but put more things in together over time. And then there's this comment here about, then we're going to be putting the as part of the programme in 6.11, looking for areas of collaboration, looking for areas of joint working. It's really hard in this committee where we only, see each other every few months to sit and go, I can see things will be better for Medway as a result. So, at what point will these now two boards be able to come together and say, right, here's the plan, it's here, it's there, it's there, it's there. And I just echo that question about, and how much time and money will be taken up in the process of getting to that point of transformation. Because it felt very much like it was an idea and a commitment, a statement of commitment, but I couldn't receive that guarantee that that statement of commitment in a timely way was going to be able to overcome these huge challenges. Thank you, Chair.
Yeah. So by all means, you can invite us back in, say, May, and then we will have the integrated improvement plan for Medway for the year. So you can see the areas that Siobhan will be leading on in terms of finance, services, quality and performance, and the cultural transformation. Secondly, we can also come back with, here's the programme for the group work in terms of the services that we're going to work together. So urology, paediatrics, digital, so that you can see both of those things. and then we can come back and present the progress against that.
Thank you, Councillor Cook. Councillor Jackson.
Thank you, Chair. I'm finding it really hard just to find the confidence in any of this. And you sort of saying, oh, we listened to you, but you didn't really, because you went ahead with it anyway, and then you come problems, and then you come back and say, oh, we listened to you. And then you use words like, you know, hopefully in 2 or 3 years. There's no plans, no like it just doesn't seem, and you might have, I'm just not getting that you have anything. You're just sort of like, I don't know, we stumbled across them, we're taking it back again.
So maybe I should, just to be clear, there are 2 separate things here. One is the plan for where we wish to collaborate in terms of clinical services, in terms of enabling areas and infrastructure such as digital and estates, and then corporate areas, corporate back office areas. That stands as a standalone plan. It's then what's the best leadership structure to wrap around that in order for both hospitals to be individually in a better place in terms of their finances, performance and quality. And secondly, where we can benefit in those improvements from working together. So the plan for bringing together and collaborating on services, that has not changed at all. What we're talking about that has changed is what do we think is the right leadership structure to wrap around that?
And that's my point. Like, we had one plan, and now that plan's, as Councillor, it looks like it's slowed down. And you said, because we listened to what the committee said and we went back and thought about it. But you did say, hopefully in 2 to 3 years, we'd have that.
So phase 1 in terms of the leadership to wrap around is for both trusts to have their own chief executive and executive teams. But over the next 2 to 3 years, there may be opportunities where some of the executive work can come together. This is particularly linking to the corporate services side. It's an evolving model in terms of as we get more and more collaboration in terms of the services at the right point, we can then look at what is the what's the next stage in terms of the leadership structure? Is it moving to 1 chief exec or keeping 2 chief exec? So we'll come back at that point and give you an evaluation of those options with a recommendation to move forward that will have come from our 2 boards.
Thanks, Councillor Jackson.
Okay, I'm just not.
Yeah. Councillor Lane.
Oh, thank you, Chair. If I did hear John right, you did say, I think, if there is collaboration, there would be movement of patients from one hospital to another hospital. Did you say that? I don't know, because I something like that.
So what we will always try and do is where we can, people being seen locally, which is a big issue, obviously, for the patients from Swale that we see. They find it hard enough to get to Medway Hospital. So there will be instances with this collaboration on specialisation where actually, so one of the things that we will look to do is to move the clinical staff to where the patients are rather than the patients to where the clinicians are. However, occasionally there will be specialist equipment, specialist surgical teams or medical intervention teams where we will ask a patient to move to have their treatment either at Dartford or a Dartford patient to come to Medway. Siobhan?
Yeah, we currently do that with, for instance, for our urology resectional cancer patients. So they will come from across Kent, actually, to Medway to have their surgery done, because that's where the expertise is. And you can't pick up a equipment and theatre team and move them to that area, because you have to have those staff experienced and well used to that practice. So We currently do that. We also share models around endoscopy, so we're working to do that. And we're not just doing that with Dartford, we're doing that across the system. We've had quite good success with that, especially bringing down our weights, which is fantastic for our diagnostics.
So basically, there will still be services that will be moved between the two hospitals if there are collaborations.
There will be for some of the highly specialized bit, but again, if we can get our digital technology program right with the modernization of the digital platforms for outpatient services, we should have actually more people being able to stay local, more people being actually able to have some of that remotely from their homes. As we move into the new digital platforms. So it will be where someone needs specialist care that they would be moving.
Thank you, Councillor Lang. Councillor Crozier.
Thank you, Chair. Just a simple question for me. I wonder whether there is a separate, or there are two estates strategies for both of the hospitals, and where I can see those online. Thank you.
Yeah, we're just bringing our estate strategy at Medway to our finance committee and then to board. So we'll be able to share that in May, June. There is a separate strategy at Dartford because they're a PFI. So it's managed very differently.
I understand that. There isn't a current estate strategy then?
Yes, there is. Yes.
There's a current one I can see now. It's the one I can see now. If it's going to change.
Well, it's currently been updated. So it's just been
see.
updated, yes, which we'll be able to share with you in probably 6 weeks' time, something like that. I'll make sure you get copies.
Thank you, Councillor Crozier. Finally, Councillor O'Croft-Scott.
Thank you, Chair, and thank you for the report. I'm a bit perturbed, really. I'm looking at page 65 and at the bottom 3.1. It says we're in the early stages of developing a group to help strengthen services for patients and improve long-term stability. But for me, you're playing the okey cokey. It's this way, it's that way, it's not. And patients are our constituent, and when people aren't well, they need a plan. And I've spent many years in leadership, and you have your operational plan and then you have your long-term strategic plans. And, you're doing the okey cokey with them. How are we going to convince our residents that this is right? Because you seem to be throwing the baby out with the bathwater.
We're not changing the plan for, excuse me, we're not changing the plan for services. So the plan for services is the same one that we presented before. What we are doing is changing the leadership structure at the top in order to take that forward.
Chair, could I just come back on that? So, leadership drives everything, in my opinion. And what I feel that we've had too much consistently is a sea of excellence, Maidstone Hospital, in an island of indifference, and you're carrying that on, in my opinion.
Thank you, Councillor O'Croft-Scott. I think, look, John and Siobhan, I know people here will be expecting me now just to go for it, right? Because, and you know what? I just get so frustrated with this. I'll be honest with you. And we do have a good communication. Siobhan, me and you talk quite a lot. We have good communication here. I cannot believe we're here talking about this structure again, right? When clearly this is a board, this is between you two boards and what you want to do, everything else. The only thing we're interested here is, we were interested when it was going to be maybe a joint CEO or maybe a joint structure or maybe saving money because the hospital's in financial, under financial pressure, etc. But then it keeps changing, doesn't it? And things change, business plans change. I understand that. But we've just spent like 30 minutes. There are still considerable issues going on at MFT. And you know what? After this discussion, if I was a staff member watching this, I'd be thinking, what the hell am I doing working here? Because and I'm going to say it because there are members in the audience here, the ICB and everyone else, Department of Health, should be sitting back and looking and thinking, what's going on here with this board here? What is happening here? You know, we keep talking about, you know, I know it was a key thing you said, John, about 2 or 3 years. I know you didn't mean it literally, right? Because probably it'd be a new board, whatever there, but we're beyond our upteenth number CEO by then. And hang on, John, let me finish, because you have answered coming back. We've heard about cultural transformation, believe it or not. Believe it or not, we were told there was cultural transformation 2 years ago, 4 years ago, 6 years. You can look at all your minutes. Democratic Services, dig them out. We've been told that the hospital's turning its corner. Cultural transformation, no more bullying, no more staff being treated poorly. We're not going to have this going on, we're not going to have that going on, we're going to save money, but we're going to have excellence. And you have got some excellent departments in your hospital and fantastic staff. But do you know, I'm going to say it, what's let them down is all of this up the top here, nattering away about a group model. Because what your staff want is a CEO. I haven't heard you say at the minute, John, and I probably will do it, come back. You will be back here, it's June, our next meeting. But we want to see then what's going to happen about recruiting the CEO. What's the plan with the CEO? And you know what? I think we need to be hearing what the ICB thinks about all of this. What does the Department of Health think about all of this? What went on in the last few weeks that changed your mind totally from one model, which we did argue about, we had a big discussion here for a long time here, not long ago, the group model, exactly what you're talking about here, because we had concerns. Something has happened from a national level or from ICB or whoever have sat around the table and thought, hang on a minute, let's draw back on this. Because Jonathan wasn't going anywhere at one stage. He was quite happy looking at the two, and I can see the synergies and I can see how it works. But something's happened. And we're not all silly here sitting around this table, right? And I'm not asking you to tell us what's happened necessarily in public, but actually something has happened, whether it's financially with Darren and you or your board or whatever, something is missed. There's a piece of the jigsaw missing here today. I don't necessarily know, because we don't want to hold you here for too long, John. But we do want answers. And I'm going to go to the 3 MPs. I'm going to ask for a round table here, because I think it is absolutely crucial. I love you, Siobhan, to come back and say we've done this cultural transformation plan now and it's wonderful, right? And do you know what? Unfortunately, we'll probably sit round here and go, oh, yeah. Purely because there's a lack of trust, isn't there? Not lack of trust with your staff, not lack of trust with individuals, yourself individually, but there's a lack of trust now that the hospital is not delivering or concentrating on delivery. Instead, the board is, I know you are looking at other things, but the board is really concentrating on this model and this group model. And you know, the biggest challenge you're going to have now is who's going to be your next CEO? Because I tell you what, you're going to need a really good dynamic person to come in, because the next poor person that comes in will be thinking, when I'm gone in a year and a half's time or 2 years, am I going to be blamed for everything that's gone wrong in Medway too? Because that's what's happened every single time. I hear it out there now. Well, the ex-CEO's gone now. And we blame everyone all the time. And it's not, it's hard. It's a big ship. It's not easy. It's not easy. But we're not doing the residents justice here in Medway. We're really not. And do you know what? I feel responsible now. I feel responsible because I always give people hard scrutiny and hard time here. But I gave the olive branch and that level over to say, you know what? I actually think there's a plan here. And it's gone. You're going to tell me it isn't. You're still going to meet with the chair over in Downford. It's totally gone. What we're now all looking around this table is we're going to wait and see who you employ. And that person that comes in, whoever it is, has to sit in front of us. And then we're going to see your staff survey. Then we're going to see your results. Then we're going to see other stuff. And we're going to be saying, what are you doing now? Well, we've decided to do something really different, and we're going to change the hospital now for the best. Nothing happens. Nothing happens. I don't really know, apart from, I will do, because like I say, I'm going to have discussions with the MP. I'm going to write to the Department of Health, and I'm going to find out what went on. I'm going to ask the opposition spokes to join me on that letter. I'm going to find out what's gone on and the ICB, because are we the only concerned individuals here about the hospital? Are we the only ones concerned? you know, and I'm going to say again, Siobhan, you're concerned because when I have conversations with you, you're so passionate about, normally it's because I'm going mad down the phone, but you are passionate and you answer me. But actually, our residents need better than this. We're not doing them justice, and I feel ashamed about it. And I don't mind putting myself on. You guys can say whatever you want and don't put yourself on the stand, but I feel embarrassed, and I feel like I should apologise to the residents, because are we doing enough to hold you to account to give a good service? Because I don't, you know, I think I've got a fantastic team here from all sides on this panel, and I feel like we've just gone and revisited the whole conversation that we had 6 months ago, and we've just repeated it all once again, and no resolution. But we'll come back to it. I know you've got to go, John. But, I mean, as far as I'm concerned, I think we need to be doing something, and I will be notifying the MPs and the Department of Health. Yes, please.
I move that the committee notes the report and the chair will investigate writing to the Department of Health and bringing together the local MPs and key stakeholders to address this lack of confidence in this report.
And I don't know whether I want to ask John, I'll leave that with you. We can take it offline about the schedule of later on of the employment of the CEO. You can give us a schedule at some point, or I know you can't now, but give us, because Jonathan's still here, but maybe we can have that plan at some point if possible. Okay. I wish you well, John, with where you've got to go. Thank you very much. Thank you. Thank you, Sean. Is that agreed, members? Agreed. Thank you very much. Have the next item up, please. Item 5, mental health services transfer. Can't believe we didn't have your name there. What's going on? We always have these names. Okay, welcome, Adam. Welcome everyone to this. Would you like to, members see you, they saw you last at the last meeting. Would you like to just give us a bit of an overview on the report and let us know where you are on that?
Yeah, thank you, Chair. Good evening, everyone. I'm joined, Sheila and I are joined with Adam from the ICB, but also from Sarah Borman, who is the Interim Service Director for Children, Young People and All-Age Eating Disorders Services for Kent. We'll take the papers as read. We've been asked to provide an update on the transition programme that's contained within the paper, and all parties are continuing to take assurance through the established governance process that's set out in the paper. Just to update, outside of the paper, yesterday both boards of NELFT and KMMH met to review the assurance processes, and we have agreed to continue with the aim of a go-live of the 1st of April, and we are any day now expecting confirmation from NHS England in support of the transfer of service. I know we spoke a great deal last time around the CQC inspections on behalf of KMMH, and Sheila would like to give you a brief update on that as well today.
Thanks, Sheila. Thank you.
Thank you. I thought I'd just give you an update, if that's okay, Chair, in terms of where we are with our CQC well-led, which is ongoing at this moment in time. So they were on site with us last week for 3 days for their on-site inspection. This week and next week, they are continuing to do their interviews and focus groups with staff. They have given us some headline feedback already, which they did at the end of their 3 days last week. We are expecting a high-level letter in the next couple of weeks. They wouldn't commit to any timeframes in terms of our report, but that will be much later in the year. The good news, I would say, is they reflected and they could see the positives of the change in the organisation around our values and our behaviours and our improvement journey and where we're going. Anything they did reflect back to us wasn't unknown. So the things that they kind of said to us, we know you need to improve here, we already knew ourselves. Last time I touched on the governance review that I'd commissioned for Morehouse. So similar to that, Morehouse recognised our improvement capability and how that's kind of enhanced in the last year. the CQC enforced that as well, which was really, really good. And we continue with the improvement in our quality plan that we've had in place for the last kind of 6 months. What I did want to share, which is really positive, so before they came in and did our well-led, they told us that they were going to be lifting the warning notice for our community teams. So that's fantastic news and recognition really of all of the good work that's going in from the staff on the ground. So just wanted to kind of share that. They also recognised the positive step forward around engagement with staff, patients and partners. And that was reinforced. So thank you, Jackie, for joining us last week at the opening, because that was really reinforced by the partners as well, and we appreciated that. But they also talked about the values and kind of where we've got to with that in the organisation. So that's kind of, as Adrian's just said, is just kind of, we just can continue forward with our improvement journey, and the next part of that journey is going to be bringing the children's service across the KMMH, which we are looking forward to on the 1st of April.
Thank you, Sheila. Thank you, Adrian, and welcome, Sarah, to tonight. Don't worry. Please don't be that worried about after the first time. We're not always that bad. Please don't be. I said I put you at the end just in case there. Adam, did you want to just comment anything? Because I remember the last meeting we said you'd meet with Sheila and look at any that them assurances around the ICB and the contract sort of thing. Just so we clear that bit. But are you reassured?
Yeah, sure. So, so we've had both the reports set out the governance process that we've gone through. There were kind of 3 main areas that we're focusing on that we therefore feel really confident about in terms of the transfer. So, as an ICB, our board have also met and have also agreed that we feel it's ready to go live, and we're confident for that. Let's be really clear. We discussed last time, however, we know that children's mental health services need to improve, and there's work to do in relation to that. However, the committee asked us to come back and give the assurance about what were the areas we were concerned about, what we're therefore doing for the 1st of April. So I'll just outline them really briefly. One was the digital readiness between the transfer between both organisations, and we're really confident by the process that has therefore been taken forward. The trust, well, both trusts would have, if we hadn't transferred the services over, NELFT would still have had to do a change of how it would therefore work in the central NHS tenant. So that has to happen regardless, and we're just getting the right slot with NHS England to make that happen in 26-27. So therefore, what will happen is the trust will basically commission NELFT to still oversee that for them, and that is a pretty standard way of doing that. We've checked that, we've got the legal basis behind that, the SLA is strong, we feel confident as a commissioner that the right things are in place to get that right. And therefore there's a second part to that, which is then, and within 26-27, it then migrates over there, and we're very happy to update the committee when that's going to happen, when that's happened and got forward. The other key areas that we highlighted the last time we met with you, we were just making sure that the safeguarding arrangements were robust for the organisation. We're confident for that going forward, that there was a robust comms and engagement plan with incoming staff going forward. And I think we've heard both sort of numerically, but also kind of that kind of touch and feel that staff are really looking forward to working with the trust as part of that going forward. But you know, the trust and colleagues can speak to that. So our approach has been, we feel assured for the transfer. However, we're then going to do a post-transfer review. So we're going to keep it on a heightened level of quarterly oversight going forward. And we're really happy to come back to the committee with anything that come up in regards to that. Also, though, this will be reported to the public board of the ICB as well. So for colleagues who want to look at how we're assuring ourselves about that too, that will also be in the public domain. But yes, confident for the transfer, but wanted just to reiterate again, we heard quite a lot of very personal stories the last time we met. We still have got work to do to improve children's mental health services. But the question for this report was, are we happy with the transfer? And at this point we are, and ready to go live.
And I will hand to members just so, but obviously with Sarah overseeing, is that a part of your reassurance pillar as well? Is that, or I mean, you're going to be reassuring us anyway. I can put you on, but is that why? Obviously, we are glad you're here this evening. Is that what you're here to reassure us around that element?
Absolutely. And I think, you know, from my perspective as the Service Director for Children's Services, the teams that we have are fully committed to, you know, the transformation for children's services, and we're really excited to be joining KMMH because, you know, as an all-age provider, we've got so many opportunities which will bring about improvements to the service. So from my perspective, absolute full commitment to take the services to a new height.
Thank you so much. Members, Councillor Wiley.
Thank you. Again, this sounds to me like history repeating itself. When NELFT were first commissioned, the ICB assured us that that was the best place to go, etc. Another group of officers, you know, they were the people that would help us with our young people and their problems. And now we're being told the same again. And we've got similar, there was only one option, which is what, you know, KMPT may have been the best way forward, but I doubt it, but they may have been. But when they're the only option, that just doesn't sit well with me. On the papers, I've written myself some notes and I was going to ask some maybe more detailed questions on them. I'll just read what I've put because, because I'm really fed up with hearing from all versions of the NHS how wonderful they're going to do things, and I've yet to see it. So at 1.2, page 20, you've put your transparent, and I totally disagree with any idea that you've been any transparency. This was given to us as a done deal, and that's always been presented. At, well, 2.3 especially, there's a whole list there of things, and the oversight framework. On this oversight framework, it doesn't tell us how we're going to measure failure, which I'm not wishing failure on you, but we should be able to know what's failing when. Page 24, 2.1.3, you launched recruitment for 7 consultant posts. Does that mean that you're 7 consultants short on where you'd like to be? And that sounds quite a gap in the service, to put it mildly. At 6.1, page 27, you say that you are confident. Well, I wish I was. And considering the history of the provision, do you agree that 6.1.1 to 6.1.5 all sounds complacent? Because, you know, the programme is on track, risks are understood, mitigated and jointly owned, clinical safety, digital continuity and workforce readiness are assured. And as I've just said, you're 7 consultants short. A safe, effective, legally compliant transfer will be delivered, well, hopefully, etc. It just sounds good statements, but you haven't left any room for we're working towards this. It's as if everything's going to be fine and work perfectly, and I doubt that very much. Well, yeah, and I'll just go on a bit on the rest of the page, so I'll leave that for now, but I have limited confidence on where this is going.
So just to be clear, Councillor Riley, because one thing I don't want to do tonight for all members is I think we've already, which is rightly so we did, and both Sheila and Adam both know this, the committee wasn't happy about the way the contract was handled and done. I think that when I say that ship sailed, I think that obviously, I mean, in the best way for the clients, obviously, it is what it is where we are now. But just for all members asking questions, it's about how we ensure the contract going forward now, which you did pick up some points about staffing maybe, if we can pick up those points, but not about the contract. I think you did get our messaging about the contract last time. We weren't happy about it.
Right, and the other points, how can we clearly understand whether things are on track or failing?
Sure. So I mean, I'll be brief. The scope of this report was, as was the ask of the committee, was as the ICB am I assured about the transfer on the 1st of April? So to be slightly challenging, the points in 6 point to those areas, if I wasn't assured now, it shouldn't be going live. So therefore, I feel confident for all the actions that have been taken to go live so the service can transfer. I'm very
But Adam,
clear.
just with that, just reassure the members, you did say as well that you will look at a longer term. I think you're going to give us that report after April, but you're looking at contract, how you contract and whether it's done correctly as an ICB,
Yeah,
right?
so there's a number of outstanding actions. So first of all is, where is our integrated children's mental health improvement plan for the system, which I think we agreed we would therefore come back at the right point in 26, 27 for that. So that's the reason we're doing this, right? So that's I think clear. And then yes, there is another piece of work where the ICB is undertaking a review of all its procurement and contracting function to therefore then come back. So I think there are a number of other things still outstanding for us to come back to you as a committee on. In terms of then this approach, so point 1.2 in the report was kind of reflecting we're trying to be as transparent now with you about this as possible. So I think we have come back and said, these were the risks, here's how we've mitigated against it. We tried to say that at certain points in this process, we were less assured, but the work we've done together has made us assured that now we can go live safely. The job at hand now is, how do we therefore ensure that the contract that has been awarded is therefore overseen? What are the performance standards in all those areas? And I can share, in correspondence, what is in that KPI framework, because that would be, as the Commissioner, what tells me is the service, to your words, failing or in need of improvement, or actually delivering things really, really well. To the staffing model, I'll hand over to the Trust to answer that question, if that's okay.
Thank you. Yeah, section 2.1.3 from the KMMH paper does mention about the medical workforce and agency cover. What currently is the situation is that there are long-term locum consultants filling those posts, and what we have done as an organisation is say that we want them to be substantive members of the organisation. So that's what that paragraph is talking about. We've gone out to advertise to substantively recruit, as opposed to the long-term locum posts that are currently being utilised for those roles. What we've done is our Chief Medical Officer has written out personally to all those locums, asking them if they wanted to become part of the organisation, and then those that do, we are helping to facilitate them joining the organisation as well. So to reassure the committee, there are not currently seven vacancies in terms of the consultants. They are filled, but they are filled with locum cover at the moment.
Councillor Campbell.
Hi, thank you for that, and thanks for the clarification, Adam. So there are some similar strands here to what we heard previously about organizations coming together. In many ways, I think we hear a lot about vision, mission, values, culture, and things in this committee. With the sort of transition of services, what we're talking about, I feel that those things kind of fall in line naturally, organically, eventually. The thing that really worries me is the actual reality when the rubber hits the ground, day one services, things like digital readiness, which there's a lot about here. So I'm going to work on the assumption that you have a change management team, change program, every asset is being mapped out and all of that. So you would do that as part of your assurance things. Can I, just for my own understanding, so NELFT systems that you're using currently, that sits within the NHS IT systems in a particular tent, and you're going to have to create a new tent and transfer these services over, but it's all sort of within the same universe, if you like. Is that right? Yeah? Okay. So, I mean, I don't really have a specific question, except that I've worked with organizational change at this level, and in my experience, things do go wrong. Things do, in spite of the best level of sort of business continuity plans and all of that. So I would be very interested to hear about how this pans out. Maybe not 3 months after the fact when we are looking at, because recently, for example, MCH a few months ago had their IT systems went down. Absolute chaos, absolute chaos. We were hearing from people left, right, and center saying, we haven't had this critical test done, we haven't heard anything. It was total chaos, and it took them months to recover. Now, you would think that the organization had sort of a plan in place for things like that, So with the best will in the world, when you're looking at things like that, things do go wrong. So I would be very interested for this committee to just see how it actually panned out in sort of as close to the timeline of real life as possible, what the risks were and how it was mitigated.
Councillor Campbell, I do think, I'm sure Adrian has it in his diary, probably the next quite a few hasks anyway, so he's quite used to that, but that would definitely be a recommendation we'd put down, 100%.
Chair, so just to reassure you in terms of the digital component, we could do it slightly quicker, but what we've chosen is deliberately to take it over the course of this year, so that we've got that buffer in place to make sure that if things do go wrong, we can rectify them without any disruption to services. And in terms of the entire of the business continuity piece, with regards to the transfer, Sarah's been working very tirelessly with our business continuity team to make sure that we've got measures in place. And in fact, actually, we discussed that at great length at the board on Wednesday as well to give them that assurance as well.
Thank you. And just to clarify, the reason I'm saying this is when I work with organizational change, those are not life-critical services like what you're delivering. And even then, the kind of damage and the chaos it causes is just enormous. Whereas what you're doing, it literally affects people's lives, right? So it's so important to go slow and steady and really carefully. So I'm glad that you've chosen that option. And I think we're all rooting for this transition to go smoothly. Whatever happened with the procurement process, we kind of all want to see this work, because we can't let young people down because your IT systems went down, or you're all having to go back to paper, because that would be a nightmare.
Thank you, Councillor Campbell. Councillor Name.
Thank you, Chair. First of all, let me say it's good news to hear that the CQC have lifted the warning from your community team, which is a very good news. To follow on from what my other colleague just raised. Now, so when it comes to IT, there are issues with it. So basically, do you have any contingent plans that is in case there should be an issue within the first week? Because bear in mind, we are talking 1st April, and bear in mind that Easter is just around the corner. So if we should go to transfer, and then there is an issue, maybe people have gone on Easter holidays or wherever they've traveled outside the country, what are some of the contingency plans that you have in place that you try to move from that issue when it comes to IT? The second one is you've identified risk, and when we identify, always there will be risk, there will be mitigation. But is there any independent body that have looked at the risks to find out, or have you dealt with any independent body to assure you that, okay, we've looked at all the risks that are possible to, should we be transferring whatever risks should come, this is the way we're going to manage it, not by the ICB or by an independent group, to give you assurance that once we move and there is any issue, we can just go through. That's my second question. And the third one is...
If we just Councillor Name, if we just let him answer them two first.
Yeah, I'll cover the handover piece in terms of sort of the Easter period and that, and we were very mindful of that. What we've done as part of the operationalisation of this piece of transformation is make sure that we've actually stood up increased services and support services over the course of the transition at the 1st of April, but also over the Easter period. Sarah and the team have also backed up that we will run a parallel on-call system with just that directorate as well, so that we've got those highly trained leaders and those highly familiar leaders within the organisation to provide that support as well. And Sheila's going to pick up on the legal part about risk as well.
Yeah, so just for the risk, we've had independent support to help us with the programme management of this for the safe transition, but we've also taken legal advice. So when we've done all of our due diligence, a legal team has been doing that for us to pick up the issue you've just raised around potential risks that we'll be taking on as an organisation. So we've had that independent support the whole way through the programme as well.
Councillor Name, question 3.
Okay, thank you very much. The third question. How will the integrated care board, let's say between now, maybe once you move between the first 30 and 90 days, how would you be monitoring how the system will be operating, and whether whatever reasons why you think there should be that collaboration, how can you show or prove that it's really working as it is intended?
So I'll do it from an assurance perspective, and then the trust will do their own internal processes. So it's a clinical service that is operating today and is transferring on the 1st of April. So therefore, the questions that we were asking ourselves are in 5 main domains. So first of all, let's start with the most important bit. Have there been any changes in the quality profile of the trust? And what that means is increased incidents, increased complaints, increased staff speaking up, or at times decrease. So have things changed that are therefore give you the question to ask, are things in the wrong shape? So they're the first things that we look at for a first level of assurance. Other areas we would therefore look at would be then things about the internal pulse survey. So what are the staff saying as they transfer over? What is increased patient feedback in relation to what's going on in the organisation? And there are other measures we would therefore look at too in terms of risk. So we'd look at, the financial sort of position that the trust is taking, and also some of the wider corporate measures that would go forward. They all form part of the contract, and therefore we're in a monthly contractual discussion with the trust as we go into this going forward. So there'll be the areas that you would look at as from an assurance perspective. Just to come back to your last question there as well, in terms of the layers of assurance. So the trust have outlined what they're doing internally. So of course the transfer between NELFT, they've got to be confident to transfer. The trust has to be confident to receive. So there are 2 levels of assurance there. Then there is the ICB overseeing it. So therefore my external view of that, and also the external advice that I've taken. On top of that, however, though, NHS England are also assuring themselves that we have put all those measures in place. So I think that should give confidence that there are enough eyes on this going forward. But it doesn't mean that when we go live, we should remain vigilant for all those measures that would therefore tell us, are things in the right direction, and has it been a safe transition? There of course has to come a point where we say it's safely transitioned. Now, how has it been managed, and how are we improving it? But I think let's get past the first bit, and then we'll get into the next bit after that.
Thank you very much. Councillor Finch.
Thank you, Chair. My point's on assurances as well, that everything will be safe on day one. But I'll try not to go over any old ground or anything. This is specifically about day one. The report states there are no identified risks that would compromise patient safety at the point of transfer. And as Councillor Campbell was saying, even if just one thing goes wrong, it could be catastrophic. But we've got a whole service transferring organisations, staff moving under 2P, IT systems still hosted by another trust, less consultant recruitment ongoing, financial deficit on the contract, stabilisation period lasting months after go live. Even the report says multiple operational risks, workforce sustainability, digital transition, Easter go live pressures as well. Yet the summary line says no risks compromising safety. So my question is, given the scale of organisational, workforce and digital change taking place simultaneously, could you explain what specific risks were considered when reaching that conclusion, and how the committee will be informed if any risks emerge during the stabilisation period? Thank you.
So first of all, the directorate as a whole will obviously have a number of risks that they hold anyway as part of their day-to-day function, and those risks will be transferred over. And we've done our due diligence in making sure that we're fully aware of that. And Sarah and the team are continuing on in employment under KMMH, so they are already aware of all of that as well. Yes, you're right in terms of some of those risks, and what we've done is we've made sure we've got absolute clarity on them, how we can mitigate them if necessary as well. And then work through whatever ones we deemed before we transferred services we were more worried about, and we are absolutely assured that those ones that we were worried about, our mitigations are in place in terms of that.
Is that okay, Councillor Finch? You got your answer, Jim? Councillor Cook.
Yeah, thank you, and thank you for the additional detail in the report. particularly looking at those last 2 pages with the mapping document, which is really helpful. A very ridiculously practical question. So we've talked lots about the digital strand, the comms and engagement strand. So I was really grateful to be able to share my story last time. You know how significant I said, you know, messaging from NELFT is for parents. And as soon as there's a hint of any change, particularly if it's going to affect our children, I know that residents will immediately be coming to Councillor Howcroft-Scott, to myself, you know, asking, is this going to affect us? And that little tiny comment that said, you know, messaging to staff and stakeholders around the change is a small box with a lot of work. So what does it look like from the 1st of April around what residents are going to hear, what parents are going to hear, and that immediate confidence building that you are doing with us and wanting to bring to the committee, that we can then pass on to our residents around, oh my goodness, why isn't it NELFT anymore? Suddenly I'm not getting texts from them. You know, what does it look like? And just how can you help us as councillors just to reassure on that? Thank you.
Thank you. So we've done lots of work throughout the programme about communication, particularly with young people and families. In clinics going up the last couple of weeks, there's been posters explaining the change from NELF to KMAH. Those posters have detailed that care will not change, the location of which your appointment will be seen will not change. Everything that you did yesterday on the 31st of March will be the same on the 1st of April. We've engaged in service user participation groups to talk about the transition from NELF to KMAH and what young people, children and families would like to hear, what information is important to be shared. We've had some really helpful feedback which has shaped our communication strategy. Thinking about the people that people trust the most, so our HCPs, the healthcare professionals that are allocated to our children and families, they will be the first point of contact. Those children that are on neurodiversity assessment waiting lists, they will receive a text message on the 1st of April detailing the change and any concerns that they have and where they can contact for support.
I'll just come back in and say, I think, you know, particularly that last bit that you said there, you know, just be prepared for the floodgates, because just being able to have someone that you can go back to and ask a question will be really significant. And I think people will really appreciate that transparency. Thank you very much, Chair.
Thank you, Councillor Cook. Councillor Howcroft-Scott, finally.
Councillor Cook took one of mine, which is great that, you know, and Smither as well, because, you know, I do think you need a contingency plan, just saying. So the final question that I have is Appendix 2, 5.4.5, please. You talk about the report talks about the contracts transferring with the deficit. Yep. You got that? Okay, sorry. I saw you looking. I thought you was a bit confused. Okay, so you expect to break even within 2 years. Can you say to me or explain to our committee here what you think the pressures will be currently, in the future and long term, and what is in place to ensure that improvement or continuous improvement and critical care and staffing levels stabilise and, you know, going forward are consistently good?
Thank you, Councillor. Yeah. I mean, in the absence of a risk register, I suppose. That's what Councillor Howcroft-Scott's saying.
Thank you. So I think some of the pressures we're experiencing currently is complexity of support that young people and families are required and are needing. And that's something that we're looking at in terms of how we can assume efficiencies with our resource as a whole directorate, looking at ways in which we can use our resources more wisely. We're going to be looking at capacity and demand reviews very shortly after arriving within KMMH. And this will really help scope the future plans we have in terms of transformation and managing that particular increase in complexity and demand. We've spoken before about our neuro waiting list, the assessment waiting list. We know this is an area of concern for many families. This is something that, again, as a directorate, we're really clear that we wish to improve on, continue with the work as a system on how we can transform that particular place. I think that is something then as a system and as a organisation we will be committed to looking at further.
Thank you for that. Sorry, as a trade unionist, I would like to also ask about 2P really. And obviously that process, how it's been managed and how you're transferring. And again, what's your contingency to make sure there are no payroll errors going forward, or do you have a contingency plan for that as well?
I'm going to answer the first bit. So obviously, we've been one of our major work streams is around workforce and that transfer over. And we spent a lot of time with our chief people officer and our deputy chief people officer working closely to make sure that that process is followed to the letter, and that any areas that are causing concern are raised, and the governance structure of the programme is designed deliberately to do that as well. I personally have spent a number of visits over the last few months with staff, and so as myself and the rest of the exec can see the leadership within the organisation, and the questions that we've been the questions that we've received, we've been able to really go back and make sure that we communicate that to the entire directorate as well. In general, we've not had any problems with that to date, and that 2P process is obviously continuing. But Sarah and the team have been doing a tremendous job on the ground of really answering those and making sure that if there are any areas, for example, on Monday I was with Sarah visiting one of the teams, and there was a really good conversation about the 2P process, clarifying it. And what we've done is we've made sure we've cascaded that throughout all the management structures within that directorate to make sure they're familiar with it. They have those points of contact as well. So in terms of that level of assurance, we've got that level of assurance that the 2P process is going correctly, and that we do have those processes in place in case anything that doesn't work. And obviously, we're a big organisation already, and sometimes errors in payroll and things like that do come up. And we've got those processes in place already. Should anything happen, to make sure that that we address that and that the welfare of our staff is always maintained.
Thank you, Chair.
Jason, I'll let you in. Last one in.
Thanks, Chair. Two things really. First, as an adoptive mum of 5 children with FASD, I will still say that I don't know a child with FASD who hasn't suffered mental health issues because people are not understanding it and diagnosing it. And to still not have it on, it's still ADHD and autism, which most children that have got a diagnosis of FASD have either one of them or both of them. I discussed it here, not with you before, but it's really important, because if we don't, you can't do a child mental health service if you're not understanding it. I was at Britton House today with my daughter, and we were discussing, the service was brilliant, I'm not going to say that, but yet again, the member of staff who was dealing with my daughter didn't know what FASD was, and had gone back and done her research in her own time and is now doing it. How can you treat someone with mental health issues if you don't know what's causing the mental health issues? 2, I was really shocked when we were here last time talking about the adult services to hear that you had lost patients in the system. I forget what the number was, but it was quite high, and then you'd lost patients. How do we have reassurance that that's not going to happen to the children?
Thank you very much. With regard to your first point, absolutely. As a directorate, this is something that we wish to really focus on in our first year within KMMH, in terms of how we can really improve the experiences of children and families. And I really take your point very seriously, because it's important that a child's formulation encompasses all of their needs. And that absolutely is the direction of travel that we want to focus on, and how we can improve that access for children and young people. So I really appreciate your point. It's something we can bring back, and that experience and the family's feedback will really help shape the future trajectory that we wish to go on.
Thank you.
And with regards to the lost patient, I think when we were describing that last time, that was around when we transitioned our services from our previous community mental health teams to the mental health together in the adult?
No, it was just that after the report that there was patients that had been lost in the system that had been in the phone calls, they wouldn't. I will find out, and I will. But it was definitely people that had been lost in the system. And then when I asked to clarify, it was people that had phoned up and missed appointments or something and then got lost in the system. No one had done follow-ups, and then they had just been left with no follow-up. And then, so, I mean, if that, it was a shocking number when we heard it, that there was all these people that were due to have appointments and then just got missed. How do we know that it's the same team or the same provider that's not going to happen to the children?
Yeah, thank you for that clarification. And as we mentioned last time, there is a programme of work that's underway as part of our operational model going forward to make sure that we look at some of those risk areas and we make sure we address that. In terms of the children and young people waiting list, that's not going to change as to how it's currently being done. So those processes will continue to be followed. What we can do is we can make sure that we pick up that learning that we've done from the adult changes that we're going to be delivering this year, and make sure that also we learn, we can help learn that, help the children and young people's directorate learn from that as well, so that the service won't change from there, but actually if there's any good learning that we can bring from the adult model, we can put that into the children's model.
Thank you, Councillor Jackson. I've only got a couple of questions, but before I move on, I think it's key to say that it's a really important point about the FASD. What Councillor Jackson has said it in this committee many, many times, and we do see it in some high-level cases. We do see it across the board. And I've got to even say the council really do have to lift the game on it, because we've had promises from the council about having an awareness month, etc. But it would be good to just make sure to see you guys maybe heading it up somewhere, but also our own council needs to be, Jackie, we need to take it back. We need to be doing something about it because it's been promised for too long. So we're going to have a look at that. Just a really quick couple of lines you'll be pleased to know from me, unusually. Just going back to those clinical systems, there'd be no risk, right, for patient safety, safeguarding alerts or prescribing, anything like that? No risk to that at all? That's a good one. And the last question, I know it's not going to go wrong, right? That's what we need to, that's what we're going to hope and we need to know. And so far, and members need to know as well, so far I think we've got the transparency now. So if something isn't going right, we can deal with that. But if something does go, if it goes wrong or something majorly goes wrong, who is accountable? Is it the ICB or the trust? Who's going to be accountable if it all goes wrong? Who's accountable?
So under the legal framework of the NHS, if there is a clinical safety issue or a regulatory issue that has broken the legal framework, that would be the trust and the trust board accountable for those areas. However, if there was a contributory element or a view that, for example, the commissioning arrangements were therefore non-legally compliant or hadn't funded the service by the right amount of funding, therefore you would therefore have a counter proposition about where that's sat. But that's how that would therefore work. Both organisations are therefore directly accountable to NHS England, and they would often be kind of the arbiter about saying which part of the system was responsible. But in terms of clinical safety and delivery, the trust, allocation of resources, the ICB.
But hopefully with the guarantees you gave of surveillance and working partnership and working together, the ICB and the trust, you'll be able to highlight any issues surveillance may be the wrong word, but you'll be able to highlight any issues. You'll be talking to each other and highlight issues very quickly. Anyway.
And just to come back for assurance, yes, there is regular dialogue between both organisations. We would, as we're doing, present it jointly, but be very clear where the responsibility and accountability sits.
Fine. Just to, I mean, thank you very much for your honesty today. I think just for the vice chair, I think Adrian, we will call you back just to see how that first few months has gone, and then we'll work a programme. We'll talk offline, and maybe I did know members wouldn't mind a development session of some kind, maybe to have a look at that a bit more in depth, and maybe not around the table. Maybe we do it or not, or do it the same where we get a bit more once you embed a bit. see what's going on and see what's happening that way. Vice Chair.
I move that the committee notes the submission from the ICB as set out at Appendix 1 to the report and the submission from KMMH as set out at Appendices 2 and 3 to the report.
Is that seconded, members? Seconded? Agreed? Agreed. Thank you very much. And thank you very much for your time tonight. Thank you. Members, Councillor Wildey, do you want to say something?
Before we move on, Councillor Jackson spoke about FASD. Members of this committee will know what it is, but people watching may not. So do you want to?
Thank you. It's fetal alcohol spectrum disorders, which is there's 448 conditions that can be caused by alcohol being drunk whilst pregnant.
Thank you, Councillor Jackson. Thank you very much.
Thank you.
Councillor Wildey. Thank you very much for your time. Thank you, members. 2 minutes, comfort break, 2 minutes only, please, if you can. And can item 6 like to come forward, please, the community services? It's not just you, Adam, is it? neighbourhood health. Adam, over to you, please.
Thank you, Chair. And I just wanted to welcome Mairead McCormack, who is the Chief Executive of Kent Community Health Trust. Mairead is the service provider for this contract, so I felt if you had any questions about the delivery of the service, Mairead will be here to answer those. But I'll take my report as read, so I'll just give a brief summary if that's okay. Colleagues are aware that the ICB in April 2025 agreed to award a 5+3 year contract to Kent Community Health NHS Foundation Trust as the lead provider, with HCRG and MCH acting as a subcontractor. And that therefore commenced on the 27th of October. Now, in the context of this is sort of based on the ICB's sort of strategic direction, but also the national direction about the left shift to deliver neighbourhood care. You'll be aware that obviously this was awarded, I've now arrived, and therefore we're now looking at, what is the right model of care for the system. And we're working to kind of 4 care models that I've spoken to the committee about before, both in my first report when I joined you, but also in my subsequent ones since being with you. But the clear part for us as a health system is to therefore get robust access to primary care, clear neighbourhood care, clear intermediate care, that bit that has to be bigger than what's in the hospitals, and to therefore design the right acute model of care for a future-looking NHS. I recognise, and I think my report when I first joined you recognised the size of the challenges that this health economy had to therefore right-size itself going forward. But in the context of this paper, what it's outlining is the process by which we're going through to deliver neighbourhood health. So across the health system, we expect over time our contract that we've awarded to KCHFT to be a driving part of neighbourhood health, to therefore make sure that we've got an integrated model between primary care, the community services, and community mental health, with the voluntary and community sector to therefore respond to that. And we're at the beginning of a work that we're therefore trying to add each year a transformation fund to that to therefore start to keep people out of hospital. It's important to recognise it's an 8-year contract, 5+3. So therefore, in reality, there's now a set of work to be done between us as organisations to therefore drive that transformation forward. So as part of that, we've started to work through what are the things we expect to see changed in the service model through 26-27. And the work we're doing through our contracting arrangements for next year are to be really clear about what services are accessed throughout the system in a consistent basis. What I have seen since being here is some great things that happen in different parts of the health economy. But the scale up and the evenness of that is pretty disparate across the history. Now, that's not uncommon because, of course, the ICB was a legacy organisation from 8 clinical commissioning groups who were empowered to do things differently. What this seeks to do is to try to give our service users an even level of service for most things, and then a targeted offer in neighbourhood healthcare where where patients need to receive it. The last thing I would say, I absolutely recognise there has been a lot of discussion about the procurement of this, and I sort of refer back to my earlier statement about we're undergoing a contracting and procurement review in the ICB, and once that is complete, I'm very happy to discuss that with colleagues going forward for some of the learning about where we've been and what we have to do differently going forward. So I'll pause there and take any questions.
Thank you, Adam. And obviously, I know it's a bit different to the last one. I think obviously members still have ongoing issues regarding the whole of the programme and its contracting, not just I know you won't just do a quick review, but it's more than that. And I still think members still have a real concern. So it may come out in the next item as well. And just for members to be aware, there's probably questions you may ask in this one that may come out in the next one too. Yeah. So because you're all up here, you might as well be ready for it, just in case it does come up on this one. Councillor Cook.
Yeah, thank you. I might start exactly there. So thank you for this. There were the kind of 2 bits I highlighted. One was about the date of the transformation plan, because all the way through we've been saying, what's it actually going to look like? What's it going to look like for our people? And we've been talking about, it's going to be secure and then it's going to be transformed. And so there was lots in there kind of starting to give us headlines, but I'm always desperate to see how does the service look different? Why does the service look different? And the bit that I then going back through it, highlighted was exactly that bit around KCHFT being the lead provider with MCH being one of the subcontractors. And then I read the next item on the agenda, and then I thought, hang on a minute, if that process is changing and the relationship between the organisations are changing, then does that then mean that there's going to be an impact on this work, because now all of this work's going to have to wait while the process we're about to talk about in the next item happens? So I was just really curious, exactly as you were just saying, Chair, about how those two things might affect each other, and are we going to find that what we're looking for in terms of the how does this look different for Medway will be held up as a result of a strategic change between the two organisations? Thank you.
So if I do what we're commissioning to be different in year one, first of all, and then we can then get into the transfer, but what the impact that could therefore be. So page 6 or page 14 in your pack and page 7 outlines quite clearly, I think, what we expect to see differently. Within our contractual arrangement with KCHFT, there are a number of KPIs within that area, therefore look to manage that. So this is somewhat different to the previous agenda item in that we are expecting this contract does deliver transformation. So it's really important. This year we are expecting to see by the end of the year a neighbourhood community front door 24/7. And when we point to the year one transformation plan, we are working we're working very well, but having very constructive, challenging conversations about timeframes, when that will be delivered and how that will be taken forward. And we focused on using the two JSNAs, both from Medway and also from Kent, because of course it's a Kent-wide service. And therefore we're looking at, what that says is frailty, dementia, palliative care, and end-of-life care are really key areas to focus on. It's also really clear about our approach for care homes, and what the really exciting part is we've got a piece of work to do regarding children and young people, and we've begun to have emerging conversations now both with the previous provider and KCHFT about what are the integrated children's services that we can therefore see together, and not to bring up the previous agenda item, that is one of the benefits of having now two Kent-wide providers to therefore bring that together. In terms of the risk about, so therefore that sounds great, doesn't it? But then what's happening with these two changes? We're very clear that we need to see improvement in what the population get in Medway, and we have an improvement plan in place that would therefore see things get better, but also the transfer, we believe, actually shores that up going forward. And probably it's best at that point to hand over to colleagues to explain how.
Yeah, so to your point about the sort of the change and is this going to be different and almost derail it? No, they're complementary, because take us back 2 years ago, the main reason for us collaborating on the procurement was for stability. So Martin and I sat down with Pat from HCRG and said, competing would not be good for our people. We need to collaborate on this, and we need to take the best of all of the organisations and put stability into this, particularly for our workforce. So we've already been in partnership now for 2 years. We've now got a model that we need to attend to, so it's very clear what we have to deliver. So we've already started building it together. We won't stop building that. So the next paper does talk about the next phase of us as organisations, but the work will not change. The work is already underway, the pathway redesign, the building of the neighbourhoods together, the building out of the intermediate care model. That is in hand, and that work continues. So nothing will get derailed by the next paper, and I'll allude to that when we come to it. But I just wanted to make that point that the work is the work. We've got to respond to the ask of the commissioned model.
Yeah, I think it's exactly that. It is that ask and what that ask is. So absolutely agree around, these are the headings, these are the areas. But we've said for a while, we really want to see, well, what does that look like in reality? What's that look like in practice? And exactly that, just that assurance that it's not another example of kind of strategic change happening that means the reality of service times will now be this, wait will now be this, seeing people this quickly will now, it's that, the nuts and bolts that I understand why it's taking time to give us that, but just being certain this isn't something that's going to make it longer before we get that. Thank you.
Thank you, Councillor Cook. Before I go to the other member, Councillor Elcroft-Scott, obviously for Adam and colleagues, I mean, there's something really missing in this paper, right? And that's children here. Councillor Elcroft-Scott, you're chair of Children's, but you're subbing for me tonight, which is a bonus, really. I mean, do you want to comment on that?
That would be great, Chair. Thank you so much. And there's a few of us here on children, so I've got a few of my team here. And also, Chair, what struck me is that there are so many inequalities identified in this paper that directly affect children and young people in Medway, including the long waits. Now, the long waits for neurological assessments, speech and language assessments, how will the community service and the transformation that you're proposing address these needs for our children and young people? Because I'm having to say, they, the carers and their families, deserve better. And in the light of what our government are doing nationally, I'm talking about the SEND reforms here, and there's an expected increase in demand because obviously there's a demand for therapists and support. What specific workforce planning is the Integrated Care Board going to be undertaking for children's services? And finally, Chair, if I may, given the implications for children and young people in Medway, Chair, I hope I'm not overstepping it, but I don't know if it's a good idea for this transformation service about children and about health to come to Children's Committee. What do you think, Chair?
I mean, I think you're exactly right, Councillor Scott, and I think the members will answer that in a moment because it is missing off of here. And I think we did ask before that there should be we would find a mechanism for Children's to also look at what you're doing there, because it can't just slip out of it. It needs to be in there, it needs to be focused and scrutinised. And at the very least, you should have a targeted paper on what you're doing with children. I think that needs to be going to the Children's Committee. But it's missing tonight, isn't it? And I think if Adam, are you answering that?
Yeah, sure. So a few things first of all. And the last question. So we're at that time of the year. So we're really transparent about the contractual process. There are a set of KPIs that we are therefore negotiating in a contract for the 1st of April. Once they're agreed, we will share them with you. So you'll be able to see exactly what that, and they sit across the full domain, and there is a broad suite for children's services in there. So apologies, it is mentioned as a specific area, but I recognise when you look at the balance of it, I take the criticism.
Yeah, there's no meat on the bones, is there?
I take the criticism. And also part of the transformation fund is also targeted on that going forward. We're still in those negotiations. We're very close to concluding it, but once we're clear on that, we can therefore take that piece forward. And that was always an expected part of this overall contract that was awarded back nearly this time last year. So that's I think the first bit. On the second bit about SEND, so we're having good discussions. So very happy for the ICB, but it's not just the ICB, is it? There are a number of statutory partners that need to actually do workforce planning for SEND, and I've had good discussions with my counterparts in both local authority areas in Kent and Medway about how do we therefore do that together. We have a piece of work to therefore review what that looks like, and then what I've agreed both with the trust, so the community trust and also the mental health trust, we might need to look at a contract variation in year, depending where SEND gets us to in terms of our responsibilities going forward. So, but we'll aim to do that in partnership with colleagues in both local authority areas. And then the last piece to take that forward is in relation to the inequalities areas for it. We're looking to have for each of the neighbourhoods a population health profile that's all age. So we can be very clear, what are the things we should be doing once in each neighbourhood, and what are the things that are targeted for particular cohorts, and children in particular parts of the patch, what is our targeted area to get that piece right. We will look to have that in place in the 27-28 contract. So every year we develop that going forward, and we're very happy to take that forward. And lastly, very happy to take things to the Children's Committee as well.
We'll make sure there's actioned around and it'd be good for us to have sight of that as well. Because we look at the whole contract, so but we'll look at a target report, after this meeting as soon as we can. Councillor Spring.
Chair. Thank you, Chair. Good evening, all. I'm standing in on this committee this evening. I've done an awful lot of listening Councillor Cook has already raised some of the concerns and thoughts that I had, and going back to that last point on the CYP, I completely agree that should be brought to the committee. Tonight I've heard that there are significant concerns which have already been conveyed in comments raised earlier by our chair and our opposition spokes, and fellow councillors in past agenda items. But this report provides and states that there is a clear ambition. It says that in one of your opening paragraphs. As a Medway councillor, my concern is primarily for the Medway residents. Can you therefore assure me, fellow councillors and those constituents across Medway that are watching, that the community service transformation within Medway and for our Medway residents, they're not going to be left behind by this transition? Because I'm sorry to say this, but from what I've heard this evening, I'm not totally convinced that it's going to go very well for the Medway residents in this transition period, and that's my concern.
So first of all, the ICB has a legal duty for the whole population of Kent and Medway. That's the first piece. Hence why the population profiles are really important to us, because that will actually be how we can be held to account for, are we putting resources in the right place? The current funding formula for Kent and Medway is one budget for the whole population, whereas historically, when you had clinical commissioning groups, you had a more delegated sort of budget for the local area. We want to be really transparent through our planning on ongoing years about where we allocate resources across the system and who gets what. So each of the contracts that we've therefore asked to be developed throughout next year has to hold a neighbourhood, what we would say, capitated contract. So it's not something which is completely delegated to the system, because of course we've got to manage risk, but we'll have full transparency about where are the resources in each part of the system, so that should give you the confidence, not this year but next year, about the money not being moved into different parts of the patch in an unfair way. The second bit then is about being really clear what are the specific requirements for Medway. So if we look at the agenda for this evening, we've described, haven't we, a hospital under significant pressure, let's be frank. And when I look through the profile of activity through the emergency department in Medway, what do I see? I see quite a lot of urgent and emergency care demand that could have been managed somewhere else. That is not a criticism of the population of Medway at all. That is a reality where they've gone. So our job is to do two things. One, as the ICB, focus on primary care and get that in a much better place in the area. People have spoken to me frequently about the issues about accessing appointments in those areas. But the second thing then is when we look at the population of Medway, there are some different frailty indices you look at for this population which you compare to others. So when we're in the paper, we talk about looking at the most frail top 5%. So if we can target those through the neighbourhood working, intervene early, we should therefore be able to get that right. So I think our challenge should be the Medway improvement plan that we've got around that. When we bring that back to you, it should be describing the data points, the financial allocation, but also the work we're doing that in line with the council on targeting the most vulnerable groups. So I think that's our key area of focus. And I think in reality, we've got quite a lot of work to do to resolve all these issues, because you've seen tonight's agenda. But I think I've given my commitment before and give it again, that we have to be really, really clear what is the Medway proposition that may be different to different parts of the system.
So you mentioned about the financial aspects of it, and then within the report there was something like 12.251 million potential shortfall. So how are we going to deal with that? We have critical issues with regards to pharmacies providing first point of call for a lot of those issues which you just referred to in the response about people going to the A&E place. But we are seriously lacking here in Medway, and we really need more services provided for us. And I know you say about it's based on a per capita, but I don't quite see it. And I'm just slightly unconcerned.
So I'll draw the committee's attention to the original report I gave to this committee when I first came here 4 months ago, and was very clear about the challenges that the system faced itself. and therefore we've got significant work to do to therefore improve primary care. So if we're having a primary care discussion, I've commissioned, as colleagues are aware, the National Association of Primary Care to look at access into primary care across the whole of Kent and Medway. No one can yet explain to me why the deprivation scale has not had an approach to it that therefore gets an increased capitation of financial funding and headcount of GPs in our system. So that piece of work concludes next month, and therefore we'll have a plan to improve primary care access in Medway and other parts actually of coastal deprivation in areas of Kent. So that's I think the first bit. The second bit then is the neighbourhood model that therefore we're designing here, which is co-developed with partners. We've agreed with the council that our health and wellbeing board will take a direct oversight of the neighbourhood development plan here in Medway, with a full financial allocation available, also linked to local authority funding too, and the role of the BCF. So I feel pretty confident that we put the right things in place to be assured that we're trying to locate the decision making as local as possible and in the right governance frame. But let's also recognise the reason this was brought together was to create something stronger and more robust, and we are at the beginning of a 5+3 year contract. So I think each year I expect to be challenged for it, but I think we're making good strides, but I can't say we've got the model yet designed, and I never committed to having the model designed in 4 months, but I did commit to having something in place next year as we go forward.
Councillor Galvin, on community services, we're sticking on, please.
Yep. Thank you, Chair. I read this with great interest, and I think having, in theory, the neighbourhood model sounds absolutely fantastic, and I would certainly agree with you that we need to take the pressure off the front door of Medway Hospital, having had to wait for things for hours to get through. And I was very, very pleased to see in section 4, you say neighbourhood model priorities year 1, and at the top bullet point was dementia and palliative care and end of life. Now, palliative care and end of life is something that I've personally had to experience went badly wrong here in Medway. So can we use this as an example? Because it doesn't show, there's no detail in this. So what is going to be different? Who are people having to contact? Where's the front door for the contact? And certainly, having had the experience of my mother-in-law dying in agony, which was a horrible experience, who would I have to ring up at 3 o'clock in the morning when I can't get anybody to help? The out-of-hours doctor's not available. We've run out of Oromorph. She was in agony. How is that practically going to be implemented? Who is going to take the responsibility for that thing of palliative care? Because it is something that is wrong here in Medway, because since I found out lots of other people have had similar problems with palliative care with elderly people and indeed younger people here in Medway. So how is it going to work in practice? That is that little bit of detail that I like what I read in the report. It sounds good. And if we can get there, it's going to be fantastic. But what is the detail of how it's going to, who is going to take the primary responsibility in that case of palliative care, please?
So the main answer is we are community providers with primary care. The first thing to say is thank you for bringing it up, because I think if we can't get end of life right, then there's no point in doing anything else. It's such a critical time for families. There's too many people dying in hospital, and it's not their place of choice to die. It's because we have not been built properly to deliver that full end of life care 24/7. People don't just die between 8 in the morning and 8 in the evening, and quite often goes wrong late in the evening and at night, where families have nowhere else to go but to the acute hospital. So we've been commissioned to do this, to build this out as a 24/7 response that is robust enough to support people's choice to die in their place of choice, where their residence is predominantly, and that's where most people want to spend their last hours. For some people it is the hospital, and that is their choice. But currently we do support end of life at home, but it is nowhere near scaled to what it needs to be. The other key partner in this really is our hospice partners. They're really quite critical in this. I think they can do a lot more with us. So we've got to build this out with our key partners, but the main people responsible, I think, are the community providers.
Just to go back, so how will you get this out to the community that you're the people that we should contact? I mean, how, are you going to, will that come through the primary care, through the GP, or will there be some sort of other way of informing the people of Medway how they can get these services?
So the ideal of a multi-neighbourhood response is that families shouldn't have to try and navigate. They shouldn't be trying to find a way through and who should they speak to about what. They need one point of contact in their neighbourhood, which is one number, one single point of access that coordinates on their behalf when they are in distress. It's the wrong time for a family to try and navigate anything, and that's the whole purpose of providing a joined-up neighbourhood model.
Thank you, Councillor Golding. Councillor Holcroft-Scott, I just want to keep it on community services, please, everyone, if we can. Councillor Jackson. I'll come to Councillor.
Mine's very community. I remember first meeting you and sitting here, and we was drawing a line in the sand, and everything was wonderful. And we had a discussion about community services, and I'm all for community services. I really am. I think we should take it away from the hospital. And we sat here, and you said that we need to communicate to the community to see what services they want and where they want them. And I spoke to you about the residents of Strood West would love for you to come out and have a conversation with them about stuff that's happened in the past and moving forward. I just wanted to know that since that meeting, has there been any consultation with residents and for them to have confidence in this? Exactly what Councillor Goldwyn just said, it's about, if you're going to do a community service, the community needs to know how to use that service. And if you're not going out there and communicating and getting their ideas and listening to them, which is what you said, I've got a bit of a menopause brain today, but I know that's what you said. I know that you said that you'd come out into the communities and ask people what community services they wanted. I just wanted to know if that's gone forward, any plans for it, and what.
So two things. We've had 7 What Matters Most sessions with the community across the patch. I've taken 6 out of the 7. I was on holiday for 1. And that was basically kind of how the ICB with partners was kind of engaging. But in May comes our new community engagement strategy, which is pretty different, if that makes sense, in terms of how we're going to do it going forward. So I think what we probably need to do is bring that back to you going forward. What have I heard from residents and residents in Medway? 3 main things is what I say to my team every day. They say it isn't integrated. It isn't in a language that I understand. And when I move around the system, and by that cannot be very big geographical bits, things are open at very different times, so I'm just really unaware of what I've got. So they're the 3 things I've heard sort of perennially, and I've heard that across all age ranges. I've heard that also across physical and mental health as well. So I think that's kind of the focus that we're going to. I'm very happy to bring back our new kind of approach to how we hear from the population. Linked to that also, though, as part of our contractual measures for all providers, we're also putting an emphasis into what they are hearing in real time from their service users too. So bringing that together for one insights bank should give us in-time feedback rather than a slight pushback I've had in some of these events about you've asked me these questions before and nothing has changed. So getting that right is kind of our next step.
Thank you. I just want a community service that the community knows how to use. That's it.
Thank you, Councillor. I am going to pick that up, Councillor Jackson, in a moment, don't worry. Councillor Shocker, and then I'll come to Councillor Wilde.
Yeah, thank you, Chair. So do you feel that the local government and the VCS EF are equal partners in shaping neighbourhood health plans? I obviously feel that local political and community leaders are a crucial part of the neighbourhood plan. But I'm hearing lots of, like, even if you look online about neighbourhood plans, there's a lot of noise around how it's quite narrow in how it's being implemented, and there needs to be much more scope for the local government, local VCS leaders to be part of those plans. So how can you assure that's not going to be the case in Medway?
I'll give a perspective, then I'll get Mairead's perspective. So first of all, there is a real risk this becomes a very narrow NHS thing. Like there is a risk of that. Equally, there has to also be a slight, this is the NHS core offer into neighbourhoods too, so getting it right is quite important, so we can be clear on that. But we had this discussion with both leaders of both councils about how do we look at the role of the Health and Wellbeing Board to ensure that local government is part of that going forward to get it right. So that's our collective commitment. And also in the neighbourhood development programme, there have been many officers of both local authorities involved in all this shaping and all this design. The key part though now is I think we've got a very clinical model of care, which I think is good, which is a very NHS model of care. But then the question is, what are the broader services that can go around those neighbourhoods? The great thing about neighbourhood care that I think as a clinician is, I shouldn't say it, but it doesn't really matter about future of ICBs or boundaries. Neighbourhoods are very local and people know them. So if we get them right, they can withstand anything that changes going forward. So that's our kind of commitment. And that's why we want them to be rooted in health and wellbeing boards, because then if a local government reorganisation changes that, we've still got them rooted in that space. So therefore make sure we've got the broader public sector partnership to get it right. What we would look as a sign of success though, would be in other parts of the country, you see shared budgets, shared leadership, shared teams. And if you imagine, we've got work in the NHS to do to get a shared team together of primary care, community services, mental health, but then you can also see social prescribing, you can see the VCSE in that. The last bit is I've had good early conversation with VCSE leaders, and I'm meeting with them next week again about what is the form of alliance that we can therefore do with them about how they can work into neighbourhood care in a way that is helpful to them, recognising we've got many hyperlocal organisations and some very large ones. So how do we get that right going forward?
Thank you, Councillor. Councillor Wildy, finally, if we can keep it targeted on the community services, please.
Well, GPs you've sort of covered, excuse me, but for many years I've been banging on about Medway deserve and need more GPs, one of the lowest areas in the country, and I've been given lots and lots of reasons and excuses why that can't happen, and in my view bad decisions have been made, and you're now saying that you're going to work to bring more GPs to the area. How much success do you think you'll have with that? Because, as I say, over years I've been told about all the problems that there is to do that. The country's short of GPs, South East is especially short of GPs. I believe us and
Councillor Wildy, I just want to say for Adam, we've got to keep it to community services and the contract. I do want to say it's not a.
Okay, but
I'm just trying to.
right.
I understand your frustration. I need to keep it to the community services.
So if you can explain where the GPs are going to come from and the numbers you expect, and you're putting more on the community to provide things. Who is going to pay for the difference between adult social care and people that people that do have medical needs, but adult social care seem to pick up the lion's share of the cost? And other points have been raised, especially on page 37. There's a whole list of services which you accept are having difficulties, but there are shortages in a lot of those professionals again to provide those services. How do you intend to cope with that problem?
Can we keep to the community services answers for Councillor Wiley under community services, please?
Okay, so well then let's go to page 37 because that's that question then. So in reality, so all those areas, if the reason they're listed is the legacy of the commissioning of this system with the 8 clinical commissioning groups means they've all been commissioned differently. So one of the purposes of this contract was to therefore try to get them to the best in class and work in that way. Some of those areas do have workforce shortages, some don't. So if I just answer the question about how we're handling the workforce challenges in Medway, I'm about to sign a memorandum of agreement with the 3 universities where we're looking to say, okay, in that context, for graduates entering year 3, what is the down payment or the commitment that we can give to those people that there'll be a job locally in our system? That's for all AHPs. I'm one myself, but also we're also having discussions about what we could therefore do regarding primary care and GPs. So that's kind of our approach to therefore take that forward.
Thank you for cutting my question short.
I'm probably going to pick it up for you anyway, Councillor Wiley, because I just wanted to keep it to community services because we've been talking, as you know, and you've been helping with it. We've been going at community services for nearly 2.5, 3 years now. So our frustrations are shared. I just wanted to keep you targeted on the community services bit. That's what I needed to do.
GPs are mentioned in here.
Because not under community services unnecessarily, but unless you're going to tell me you're bringing tons of, you want to spend 10 minutes telling me you're going to bring tons of GPs in, Adam?
Politely, the brief was about community services and neighbourhood care, and GPs are central to a robust neighbourhood care model in this system. And if we don't do it with them, then there is going to be a problem in terms of gaps in care provision. So that's kind of why it's mentioned in the report, just for the avoidance of doubt.
But it is true, we have a significant issue with budget with GPs and with the amount of GPs we have. It is true. So I agree with you.
I wish the rest of your party did. But...
Thank you, Councillor Wiley. Are you finished, Councillor Wiley? You done?
Yeah.
Could you just turn your microphone off, please? Thank you. Just your microphone. I don't think I'm going to spend long on asking much, Adam. I think what's been clear today is normally I hope, and I think members hope that at least some of us do, we should be all over this community services stuff because we've lived and breathed it for 2.5, 3 years. And like I'm going to say the same thing again because we've had it from others tonight. It's like they're the same record, not from members, but you know where we see in regurgitated contracts, etc. It hasn't been a nice. You know this, Adam. It hasn't been a nice time for this for the committee. I suppose it hasn't been nice for partners as well. But the one thing I do need to say is I'm totally confused. It's almost as if, and I will say this with the lead partner as well, you need to be coming back here and we need to be telling us what's going on. We need to know where's that open door. We need to know what's so much better in different services. We need to know what not just that one page, which Councillor Wiley rightly said. We need to, you know, I asked this question before that all these were given quick bits of money just to quickly just carry on for a little while because they were coming to end of contract. And you had to deal with that emergency too. But this contract, this community services wonderful thing was painted so vividly by the ICB as being the thing that's going to change everything for the whole of Kent and Medway. And I'm still no clearer. I know that there's teams out there doing a good job, 100%. But we're not clear. If members are not clear on that modelling and the open door and what it's doing and what it's doing in all our communities, and I even say like Councillor Crozier out in the you know, out in the rural areas, everything. If we're not all clear around this table, then I don't know what other people out there must be thinking. We know it's service as usual. We were told that by plenty of your officers, Ed and others. Service, like you know, everything will stay the same, but it's clearly not staying the same because you've got issues. So. I think we need to have a chat. I know we are going to have a chat, but I think we need to have a chat about how this committee understands your way forward. And if I keep hearing about this plan and when it's going to be ready and when it's going to be done, I don't think we're ever going to see this wonderful The ICB have been talking about this transformation plan and now it's going to be wonderful. And Adam, I know you did look back on loads of these meetings. I think I've been saying about this plan for a long time, and it was the one thing that the old, you know. I don't want to say your predecessor, but your people before you and all of them, all officers before you said, wait until the plan. But I don't think it's going to help us that much. So I do need to just say that I think we need to be educated and helped in a way forward to be able to hold the partners to account effectively. We need to know where the pressures and stresses are and where the successes are, and I don't think we do. Do you want to come in, Martin, before your next item?
Yeah, thanks, Chair. Quite happy to bring back local plans, which would be the detail I think you're looking for from the provider. So I met with the GPs, the clinical directors last Thursday, so looking at how we integrate those into MDTs, how we use the healthy living centres, the James Williams Centre coming on stream next week. So all of those things, we can bring back the detail of those, because as discussed with Adam and Wade, the plans have started. We're not pausing this while we look at the other work, the next item. This is going on. As Adam described, it's mainly a clinical model at the moment, but we're building on some of the co-location we used to have with adult social care, building on the VCS, the framework. We had over 1,000 signatures from different VCS organisations. They should all be part of the neighbourhood teams. So I'm quite happy to bring that back in detail to say what's happening locally and how we're utilising that. So I think that get the detail that I think you requested.
I think that's really good, Martin. And you know, but then again, we're going to be talking. Well, we're going to briefly talk about the next item in a moment. But I think that's really good. I think it's a bit wider than that, though. I know you're all still doing the jobs, and both of you, I did say, please come back, please start, and we will be calling you back now. We're going to call you back to give us a full plan, and I would expect to see you guys here, because the community services wonderful model is there, and it's there to be. To go and hopefully make things different. We need to work out how all those bits of the jigsaw fit into that to make it different. You don't need to answer it all now, honestly, because I know it's late, but we have a bit of work to do, I think. It's not me criticising it, but you've got intelligent members around here that most of them don't, and they've been around a long time in health and other committees, children's health, everything, but none of us know where that open door is. We're you know, and we're immersed into it, unlike residents. So, Vice Chair.
I move that the committee notes the submission from the Integrated Care Board as set out at Appendix 1 to the report. We're also requesting that a report detailing the impact of community services on children in Medway is to be brought to both the Children's Committee and ASK as well, or just the Children's Committee? Okay. Yeah, that's it.
Thank you. And we're also we can discuss offline how we talk about the session about how we get a bit more. But KCHFT will be called back to the next meeting to tell us what they're doing on their services. Done. It's done. Thank you very much. Is that seconded? Agreed. Agreed. Thank you. Thank you, Adam. I think you're staying here for this item for a moment, aren't you? Going on to the next item. Who's introducing that next item? Before I just for all members' benefit, I will come in straight after the introduction on this one, if that's okay.
Thank you, Chair. I'll start and then Martin can chip in. So as I alluded to earlier, we formed a collaboration a couple of years ago, and when we bid for the community services procurement, and that alliance has really started to review how we deliver care across the whole of Kent and Medway. But for this particular area, we're going to home down on the population of Medway. It became apparent very quickly when we started looking at our data and the services that we were providing that patients were getting different offers, inconsistencies, unwarranted variation, sometimes poorer outcomes. And we could see the size of the opportunity to deliver that consistent offer across the patch, but also we both recognised an underinvestment in community services and collectively wanted to scale our services, and particularly the opportunity came along with the transformation and building the neighbourhood health model. I think it's safe to say we've got similar challenges as well as two organisations, different challenges, but also similar challenges. And the things that we want to do as part of this integration are quite key, which is, and they're named in the paper, so just forgive me for repeating them, but they are the four main things, which is to offer consistency for the population and take out the unwarranted variation, to manage the complexity in the population and in particular the access and the waiting lists, which we absolutely both believe are not acceptable and we can do a lot better, particularly around children's services. We've got fragility in our small specialist teams that we need to address. And notwithstanding, there is a substantial financial challenge. But the biggest opportunity for us.
Your microphone, sorry. Not working.
Mine's on. Okay, it's working.
Yours on? Okay. Okay, good. I think we're back on. So to that end, we now have recognised that certainly 5% of the population here is using just over a quarter of the resources across the system, which inevitably, if we talk about patient experience or population experience, those people are cycling through a number of contacts through health and care, not really getting better outcomes, and most of them going through admitted profiles in the acute trust, and that's not a good experience. And just to quote one number that I think, to give clarity on where I think we're going to focus in year one. I seen in the quality papers at the Medway Trust for last month that approximately 30% of older people did not need to be either conveyed to hospital or admitted to hospital. That's 30%. That is a huge volume. And part of our integration is to build out that model collectively so that we can give people a better local offer. And for me, fundamentally, this is not about taking something away from Medway. This is about putting more into Medway.
Chair, if I can just give it from an MCH perspective, just the reasons for sort of entering into this.
I just want to, without wasting your time, both of you though, it's just about highlight, because I'm then going to make a statement about where I think this paper is this evening. I think that's more important for both of you. Mike, you can say something now that, because you are a local partner here as well, but I just want you to know that I'm gonna say something about where I think we are with this paper and the planning of this paper to this committee this evening.
Okay. I just wanted to take us back about 2011 when MCH was set up. It was under Transforming Community Services, so it spun out of the NHS. At that time, there was a lot of promises centrally about levelling that up. Initially, there was promises around VAT, pay awards, all those aspects. Over the years, they have not been guaranteed. So I think I've been here before. We've had discussions on pay awards aren't guaranteed. Every year, we've had to argue that as part of the NHS sort of wider family. Pensions was an issue, access to NHS pensions. That's now been successful. We resolved that. There's sort of a number of those other aspects, though, access to training funds, sort of research monies that, again, impeaches as part of being a CIC and not an NHS body. It's for those reasons, looking at the future sustainability of running a CIC, as Mairead said, there's a financial, and Adam described earlier, the financial sort of deficit across the system. It's getting harder and harder to find those efficiency savings. MCH is one of the lowest overheads, so even though we're a small organisation, we have really low overheads. But it's only so we can only go so far and keep reducing the paper clips. So the issue that trying to look forward is how do we make sure we're a sustainable organisation while not impacting on patient care? And it's that that's really drove us, that working on the back of the collaboration for the procurement, there's benefits there, but actually by coming together, we think there's a range of benefits that take that further, which are set out in the paper.
Thank you, Martin. And members, look, I think it's a really important paper that you're bringing here tonight. Such an important paper that, you know, some people would say it's almost like is this a merger, really? Or is this a takeover? Plenty of questions people could ask, right? And MCH has been a local service. And I do remember the discussion we had, including when this come about, being an ordered contract, will MCH be safe, blah, blah, blah. I remember that in this, right around this table, we were told you'd be perfectly safe as an organisation in Medway. We were told that by individuals in this room today. But I understand things change, and it's fine. And you know, organisations can make their own way, and there's reasons why they have to make their own way. But I think when you're coming to a committee that's looking at looking at access to health, which they almost go together, don't they? These two, the previous one and this one. Then surely your board members, your chairs, would be here. Because what I don't want to do, I don't want to hear about we're on stage 2 or we're going to stage 3 and we're going to move it to another model and another cycle. If you're going to merge, do it. Because the residents are going to be in the midst of all this again. And I'm sure your boards have got the plan. They know what they're doing. They're going to merge. Or they're going to take over, KCHO, but you're going to take over. And you know what? Fine. But this board, like I said at the beginning, we deserve a bit more than that. Martin, you've been coming here a long time. We deserve a bit more respect than that. And your chairs should be sitting here. I'm not going to make no decision today. I will defer the item and I will go to my ops spokes to agree it until your chairs come back here. Because why is your board not here doing this? Because you're operational, you do good jobs. I know it. But where's your board members? What is going on in the health sector now? Adam, I'm going to ask you, what is going on in the health sector now where the boards are hidden and it's you guys having to come and take it from us because, you know, we're going to move. Ultimately, you are going to take over MCH, am I right? We know that. You know, we're not going through these steps here. But if you're going to do that and we're going to take over and you're going to do what you're going to do, at least have your board chairs here. And if your board chairs are not here, then effectively you're not coming here telling it's changed. And you have got your chairs, or your vice chairs if you haven't got a chair maybe. But you have got people here, and I think we deserve that. I mean, that's where I think I am with this. I don't think we should be discussing this time and time again when I know for a fact members here, I can almost point to Councillor Wildy, will be asking for your chairs to come back here. And that's what this committee should have on such an important decision, whether one organisation is much better than the other or whether it's cost effective, which I can see it, I can see it all. But where's the reassurance from your board? Because all I've got is yourself and the ICB. I know, Adam, you're not signing this off, etc. But I've got the ICB and you. Where's your board? Where's your board members here today? And effectively, we're the ones that represent the residents. We're not here representing the organisations, are we? Although we have used your services many times. But there's tons of reassurance questions I would want to ask, and I'm sure members would as well, that it's unfair to put that straight on you two, because it should be your board that be telling us that. So we'll be calling your board chairs to the next committee and asking them the same questions. But all right.
May I just come back, Chair? So my chair was here and is, as you can hear, unwell and has left. But what we did agree, and if you remember from previous conversations, we did agree we would come collectively when the full business case has gone through both boards. And that was the time that we believed that we would bring chairs with us as representing the board decision on the full business case. So I'm sure they'll be very happy to come. And that seems timely to bring it with the full business case.
And it's no disrespect to you at all, Mary, but you're at your decision. You know where you're going. You know you're taking MCH. We're not, you know, and again, that's the decision for you and your board. But we know what's happening. I suppose just come here when it's at that next stage and when you're signing off because we know it's happening. You know, it's no good us all having a go here, all of us asking questions here tonight, telling you, oh, well, what about Medway residents? What about the staff? What about Chupi? Are you going to lose staff? Is MCH, what's going to happen to your buildings? What's going to happen? When actually you'll be back here again shortly because you'll be telling us you're going to take it over anyway. What's the point? And I mean that in Maureen, you don't know me that well. Martin knows me quite well. I mean in a respectful way because, again, I'm going to say it, your staff deserve to have a proper decision, not to keep being debated around a table here when they might be worried about their jobs and their roles and what's going to happen in the future. I think we don't want to hear a stage 2 and a stage 3 and a stage 4. We want to hear what you're going to do. And it's definitely clear you're taking MCH. And if you're going to prove me wrong, wonderful, but that's definitely what you're going to do. And I'm not seeing much objection even from you, Martin, on that.
No, I'm happy to bring that back, as Murray said, with chairs for the FBC. I think that will give you the assurance of the rigour that we're going through in terms of due diligence from both organisations, in terms of TUPE of staff, novation of contracts. Just to assure you, buildings will stay. They will novate across. So MCH signs the lease for James Williams Centre. That will novate across to KCHFT. So the plans are there, as you say. But we can go through that rigour and assurance that we're going through as organisations and as boards at the moment.
And I appreciate that from you and both of you again, but you've just said, Mike, don't worry, the buildings are going to be fine. So we know it's going to go. We know you're merging. But, you know, let me just check. Can I just check with the opposition spoke? Are you content with my way forward? Councillor Wiley?
Yes. I would also like to know, when you've grown before, how that's worked out and any problems that have happened previously.
Do you mean in the initial collaboration?
You deliver services across a very big area. You've taken over, is the wrong phrase, other MCHs in the past. How they have gone, what's happened, what's gone wrong.
Thank you, Dan. I don't want to go into, Dan, honestly, I'm just checking with the other. I don't want to open to members if we're okay, because we're going to call back. But Councillor Crozier, are you content? Councillor Finch, you content with that calling back? Adam, did you just want to come in?
Yeah, so I think so. There's an outstanding action between us both about signing off a memorandum of agreement across this committee and the NHS. So I think I should take that action to work with you as chair and perhaps with vice chair about getting that agreed. So therefore we can be clear going forward then, you know, expectations, therefore, for, you know, for the initial discussion, who comes, how we do that, so we can get that right. And I will take that action with you to make sure we're clear for all these things going forward, what the committee's expectation is, and I can therefore coordinate that across the NHS.
And definitely the chairs at the next meeting. Councillor Conway, I wasn't going to open to members, but do you want to come in, because I'm not opening to members?
Yes, I would like to come in because I'm only subbing tonight. I've got to the age of life where everything seems to have gone wrong in the last couple of years, so I've had a mystery shopper tour around a fair part of Medway's NHS, and I can honestly say that MCH has been outstandingly the best part of it. I've had a terrible time with primary care. I've had an appalling, well, two appalling experiences with Medway Hospital, but MCH has been outstanding. I've had at least 4 services, if you include phlebotomy, and they've all been absolutely outstanding. What worries me is that when we've had, in the past, had joint services with the rest of Kent, Medway always comes off worse. And I'd like an assurance, if not tonight, but if somebody could ask the question, Dan, can you assure me that none of the present services that are offered by MCH here in Medway will be taken away and we'll have to go down to Maidstone or somewhere else for them?
That would certainly be the questions that Councillor Whiting, we'd certainly be asking that, don't worry. I mean, and it's lovely to hear that you had such a positive experience. You won't be having that again from MCH because it'd be different. Okay, Adam, we'll take that offline. Vice Chair.
I move that this item is deferred until such a time as a fully thought out business plan can be brought to this committee by the chairs of the boards of both KCHFT and MCH. Can I just temperature check you guys? Are we looking at June? Would you be able to come back here? So the decision with the boards, so we have made that decision. June. We'll be back in June for the decision. Yeah. Thank you. Thank you. And
Is that
memorandum of understanding, but that's
memorandum of understanding? We'll take it with Adam. Yeah. Okay. So is that seconded? Seconded deferral. Agreed, members. Thank you very much. Thank you very much for your time. Thank you. Okay. Item 9, Jackie, are you introducing this or Sasha? Take the item as read, please, Sasha, but just for members to be able to ask you questions. But
yeah, happy to take the paper as read and happy to answer any questions.
Well done, Sasha. Fantastic. Members, anything on the CQC report? Councillor Scott.
Yes, thank you for a comprehensive report. Can I go to page 90, please? Section 4. Oh, I think I'm in the wrong bit. I'm sorry. I'm in the wrong bit. I'm so sorry. I'll hold that question, if I may.
I saw you.
Thank you, Chair. Mine was directly on page 83 of the bundle regarding the validity of patient feedback. The report highlights a risk of engagement fatigue, low return rates for feedback mechanisms, which limits insight into the lived experience of residents. Now, if I interpret this report in my reading, the continued progress based on data that suffers from the low responses, how are we going to be confident that the Transformation Improvement Programme is actually addressing the genuine needs of our most vulnerable residents?
So we have a significant amount of work underway at the moment to improve engagement and co-production is what we're aiming to move towards. So in addition to having a transformation team within my remit, we've also developed an engagement team whose entire focus is on how do we improve that engagement with communities, with the voluntary sector, all of those sorts of areas across Medway. We've recently developed community involvement groups in 2 areas of Medway. A third one is about to go live, and then we're developing further ones across every area of Medway, so within every town. We're seeing quite good engagement within those and using those as a starting point to then develop further. We're also going out and seeing people where they are already, so we're not necessarily expecting them to come to us in those community involvement groups. Sorry, I've had that cold everyone's had. I keep losing my voice. So we are going out to those voluntary and community sector groups that already exist, the dementia cafes, all of those sorts of groups to speak to the people where they are and where they're most comfortable. And we are seeing a significant amount of feedback from that and acting upon that as well. So I guess all of that to say, yeah, we have a really robust engagement plan. We have a plan covering at least the next 2 years. There is an intention to create a co-production board. We've just agreed that. So having those people with lived experience as equal partners alongside us in decision making as well. So quite a lot on the table to further improve that work.
Thank you, Councillor Spring. Councillor Galvin.
Thank you, Chair. In paragraph 4.2 of the report, we're told that development across all themes continue to trend positively and that overall the direction of travel remains positive. And it's now a year, isn't it, since the CQC report was published, and this authority has put a large amount of money invested in the service. But when you look at the report later on, at the One Medway Council Plan, the performance indicators for this committee, 70% are below target and 63.6% are travelling in the wrong direction. Why the difference between the 2 reports, please?
I'll come in on that one. So there are 2 different ways that we're recording. So the transformation and improvement plan is specifically based on the outcomes that have been identified from the CQC. They don't look at that data specifically. So there are waiting lists still, and that we talk about that in the next report, but they are reducing. But it's taken us some time to get across there. So when Sasha is in the paper is talking about those themes, they are the areas that the CQC identified as needing to improve, as opposed to our local performance data.
Councillor Campbell.
Thank you, Jackie and Sasha, for this report. It's really positive that all the separate strands are being addressed and you feel the trend is moving forwards. It's been a year since this inspection and the requires improvement assessment. And you know our services inside out, all of it. Every time Jackie speaks, I'm always struck by how deep your knowledge and understanding and grasp is of the services. So if honestly you were to assess this today after a year, are there any of these strands that keep you awake at night where you think we are not going to make the mark if there were another inspection today?
I was asked the very same question by our chief executive a couple of weeks ago. So I think at the moment we probably would be bordering. I think we'd have definitely improved. So we were at 59, and I think we'd have definitely increased a couple of points. The challenge that we've got is the demand. And the numbers that are still coming in, and how do we keep up with those? And you're quite right, we've had significant investment in adult social care, and that's been fantastic, but the demand has not stopped. And it's so looking at how we do things differently to try and keep on top of that. So everyone knows that we've talked about using magic notes, and we use magic notes so that means that our social workers and frontline staff aren't having to write everything up. They can use that to try and create efficiencies. Sasha is working at the moment introducing another tool called Bebot. I'm not going to try and explain what it is, but again, it uses AI to support. So if somebody refers to us, it will say, should this be a safeguarding or should it be a Care Act assessment? But it's people that then make the decisions about that. So it's moving things on, and we're looking at how we can do those sorts of things in the division so that we can try and create some efficiencies and still do those improvements. So I think so it was 2 years ago the letter came. It was a year ago. So it was a year ago the letter was published. It took that sort of long to get through. So we're working on the premise that effectively we should get a call any time now. We don't think we will, because CQC is still finalising their last assessments and so on at the moment. So I think we're nearly there, but we've still got work to do.
Thank you for that. Specifically, though, the 6 quality statements that were assessed as requires improvement, out of any of those, are those still of worry to you, as in you're just not making enough progress on any of them?
No, every one of those has had a significant amount of work done. I think if we talk about safeguarding as an example, so that was an area for improvement. We are absolutely able to demonstrate the work that is taking place to improve in those areas. We've got the Social Care of Institute and Excellence in working with us at the moment as a critical friend. So they're looking at the improvement plan for safeguarding specifically. And they've told us that it's ambitious and it's robust, and that they're really impressed with that. And then they'll feed back to us to say, actually, we think you could tweak things here, there, and so forth. So I'm absolutely confident that we can demonstrate the work that we have done over the last 2 years. Obviously, you then have the areas of feedback from people and how people feel about that. And that comes back to that engagement piece. How can we make sure that what's being fed back to us that we're working on? But it's not easy. I wish it was, but it's not.
Thank you very much, Councillor
Thank you.
Campbell. Councillor Wiley.
Thank you. Taking that point first, inspections. A few years ago now, we had children's inspection, which turned out worse, much worse than we were expecting. The adult social care inspection, possibly we were expecting slightly better result. You're not sounding complacent, but by what you've said, that could be seen, that things are improving and we're holding our own. How do you double check that your opinion, I don't mean you personally, the service opinion is double checking itself? I probably haven't phrased that properly, but yeah.
So we are about to start our self-assessment, which is based on metrics that are publicly available and assess us against those thematic areas that we spoke about earlier. So we've got a significant amount of work starting on that. So that is our again, sorry, losing my voice. That's our real kind of robust way of measuring ourselves. However, throughout all of the projects that we've had ongoing, we have a benefits management process. As part of that, we collect and scrutinise evidence on what we are saying we are delivering, and that's a piece of work that I've given to my transformation team to make sure that we are not just taking it as given that we've said we've completed that action and therefore we have done it. So throughout that process, we are collecting, reviewing, etc., that evidence as well, and all of that will help to contribute towards that self-assessment in addition to the metrics that I just mentioned.
Are you using outside peer mentors or anything like that?
Yeah, I mentioned the Social Care Institute of Excellence, so they're doing the piece of work for us around reviewing what we're doing with safeguarding. I've just spoken to Partners in Care and Health, so they work alongside the Local Government Association about coming in to review our long-term care and support service. So is that working in a way that we want it to? Is it working effectively? Is there anything that we could be doing differently? We have we talk about the engagement team, that real feedback from people that are saying to us, actually, we don't think this is right and it's not working effectively. I think when we did our self-assessment back in 2024, I think it's 2024, we developed it in 24, we actually, when people are asking us, we were saying that we think we're going to be requires improvement. We didn't think we would be good. And so actually we knew ourselves very well. And when we got the report, there was nothing in there, I think we said before, there was nothing in there that was a surprise. So by doing the work we're doing now, learning from that, but also learning from other local authorities. So we're looking at those that got good, those that got outstanding, what have they done differently that we haven't, and then how do we build on that? The key thing is absolutely the feedback that we're getting from residents. That's the thing that will tell us if we're doing a good job or not.
Okay. Some more questions, sorry. You mentioned Magic Notes, and I've forgotten what the event was called in this room, but yes, it's very impressive. But then within a few days, I read a national report saying that some social workers aren't checking the written notes by the AI as regularly or as thoroughly as they should. And I know we've spoken about this, but can you assure us that our social workers, do?
I can do that very briefly. So we've got a very robust audit framework, and we have all of the assessments, safeguarding concerns, everything. There are reviews, deep dives, and so on and so forth. If I read something, I can tell, generally speaking, if it's been done from Magic Notes and there's been no input or oversight. You can. I know it sounds silly, you can feel it. And so we would then push back, and those audits then help us learn from that. I have to say, from when we started to where we are now, it's very rare for me to see something where actually that human interaction hasn't happened as well.
Right. Two more questions. Page 74, 4.4.10. You talk about all cases are managed through a RAG rating approach. With the highest level of need prioritised and urgent situations are managed immediately. If that process was working consistently, you shouldn't really be in the position of needing to firefight. Now, I do understand, problems escalate quite quickly, but that's one question, if you could talk about that. And domestic abuse is mentioned in a couple of places, which I've asked this question before. I've never been convinced that we provide the same services for men that are abused as we do for women. And I don't mean the same number, because we all know there's a smaller percentage, but that's always concerned me that they're not picked up on or dealt with as equal relative, as well as men, as well
John,
as
answer
women.
them, Jackie, yeah.
Yeah.
No, that's no problem. So with regard to your first question, the escalations would happen regardless of whether we were doing reviews or not, because people's care and support needs change. And so we get something that comes through to us to say, Mrs. Smith needs this because this has happened. So even if we were on top of our annual reviews and they're happening all the time, that's natural. That's nature of adult social care. People's needs, care and support needs change. So that will always be the case. With regard to domestic abuse, I can tell you certainly there's cases at the moment where that's happening, and the domestic abuse service is actually commissioned for all genders. So when we come across that, we're able to signpost and support people in that area.
If I can come back on that, because of numbers, obviously, you can't provide the housing that you can for women. Are men... do they tend to have to cope with a problem by themselves, not surrounded by others that would support them, etc.?
So it will obviously depend on the circumstances and about how we support, but we will work with our partners. So from an adult social care perspective, if we need to find somebody somewhere to live and move somebody out because it's an immediate risk, we will do that and we would fund somebody to move into a hotel. But then we would work with the commission services to enable us to make sure that that person is safe. It's very difficult, sometimes doesn't always constitute safeguarding because you have to have Care Act eligible needs to meet a safeguarding concern. So in those circumstances, we would signpost, we would work with public health and so on and so forth.
Could we have a briefing note on the numbers and whatever you can tell us without breaking confidentiality?
What is it you want a briefing note on, Councillor Waddy? You want a briefing note on how many men are suffering domestic abuse and what kind of help we're giving them?
Yes, how they're supported in comparison to women.
You want that from adult social care, or do you want it from the police as well? Who do you want it from?
Adult social care.
Okay, because they link in with the police as well.
I think it would be, we would not be able to give you a true reflection of what's happening across the system because, as I say, for a safeguarding concern, somebody has to have Care Act eligible care and support needs. And there are a lot of people that suffer with domestic abuse that do not have support needs and they don't for their meet the safeguarding eligibility.
Jackie, can we take
So
can we take it away and see?
Yeah, that's fine.
And then we discuss it with Councillor Wiley.
Yeah.
Okay. I'm moving on. Members, I just want to say, can we keep the questions direct and the answers quite succinct? Because we are moving up to that golden time where Democratic Services tell us we should cut off, but we won't, but we should. And I'm very aware that they have been here since 4:30 or 5 o'clock themselves. So I do need you to only ask direct questions. If you don't, I will cut you off. Councillor Scott.
Yes, thank you. Page 75, 4.4.12 to 4.4.14, deprivation of liberty. So the report indicates 248 cases awaiting allocation and a further 138 in call to protection. So my question is, what current expected timescale, if you have one, do you have for clearing these backlogs, and what additional capacity is being put in place to ensure our most vulnerable are not waiting for excessive periods for legal safeguarding?
Okay, I'll combine. So if I do the first one, the 4.412, that number has actually come down significantly since the CQC, and we've done a huge amount of work to reduce that. A number of those are people that are already under adults and they've run out, so they'd be in hospital or be in a residential home. So again, if there's risk or concern, they would be escalated to us. But the head of service is doing a big piece of work with the team at the moment to bring that down further. With regard to the court protection doles, they take a lot longer, so we actually have to go to the court. We go to the court protection. So the doles ones we sign off ourselves. We authorise those, but they take longer because you have to go to court. It can take months to go through those, so that's always a bit of a challenge for us, depending on the court waiting times as well.
Thank you, Councillor Scott. Councillor Crozier.
Yeah, sorry, Chair. Oh, thank you, Chair. Just a quick question for Sasha, just to check that you're coming out to the peninsula to consult with residents. And whereabouts will you be going?
We are. So there is an intention to create a community involvement group on the peninsula as well. I don't have the venue to hand at the moment, but I can find out and let you know afterwards.
Thank you, Councillor Crozier. Councillor Nang.
Thank you, Chair. On page 74, 4.49, the annual review backlog has only reduced from 1,292 to 1,100 over the past year, despite new pathways and recruitment. So I just want to find out, are there any concrete actions, including contingency plans, that will guarantee that this backlog will be cleared within a defined time frame? And how will this service ensure that that problem does not return? Thank you.
So we have an action plan in place about reviewing the to reduce the annual reviews. Part of the problem is you do 10 more come in, so it's making sure that we keep on top of those, and so starting at new ones coming in, old ones coming in, and shrinking those down to get to the place where we're in a good position. Target is 80% that we should be achieving, but we've been told actually that's high compared to national, so we'll be looking at what does that look like and how do we bring that down. And so the plan is looking at how different teams can do the reviews, because it doesn't need to be a social worker that does them.
Thank you, members. You've been perfect so far. Councillor Wildy, is it a direct last question?
Of course it is. Simply because you're more concerned about time, I shall be as quick as I can.
Concerned
And
about
I'm
our
not
democratic
waffling at all.
officers.
Right. Jackie, with Dole's, which is deprivation of liberty, could you at some point give us a briefing note on the percentage of our numbers compared to national figures and our local comparators, please? Thank you.
Vice Chair.
I move that the committee notes the progress against the CQC improvement and wider transformation plan, which addresses the areas identified in the assessment. Further, we've requested a briefing paper on what support is available to male domestic violence victims from the adult social care perspective, and a second briefing paper comparing the rate of deprivation of liberty within the Medway context as against national context.
Is that seconded? Agreed, members? Agreed. Thank you very much. Moving on to item 10. I know Yasmin's not here. She's got what I've got as well. And Dave, would you like to come up? I know you've been hiding back there. I know you've got the flu, but there's some of us up here suffering as well. So you can come and suffer with us and sit next to Councillor Wildy with that flu. Have a chat to him personally. Okay, Jackie, is this you? You going to do the early help for us?
Yeah, yeah.
Important
But
item.
the same as we've done with Sasha. I'll take the report as read and open to any questions.
Councillor Spring first.
Thank you, Nice. Bother. Section 2.3 within the report states that the local authority must identify adults and carers whose support needs are not being currently met. But what outreach mechanisms are being used to find those individuals, particularly from, as it's stated in the report, the seldom heard groups? And I think it's pretty much touching on what Sasha said in her last answer, but we need to reach out to those before they reach a crisis point.
So I can confirm that my engagement team are working really hard on reaching out to those seldom heard groups. So again, lots of those voluntary and community sector groups that we weren't previously engaging with, they've made a real effort to go out and speak to those. And they're still working on identifying those further groups all the time. We've also made a real effort to change the way that we collect data around those groups so that we can start to identify more who we are and aren't engaging with, I guess is the easiest way to explain it within the data that we have, so that then we can look to reach out to other groups that we haven't yet identified.
Good question, Councillor Spring. Councillor Scott.
Yes, thank you. On page 90, section 4.4, the report states that there are lengthy delays in making initial contact, which is impacting on preventative options and increasing the number of adults waiting for assessment. I wondered, Jackie, if your officers could clarify what the current average wait is for first contact and what measurable improvements can we expect from the new process?
Yeah, absolutely, we can. And we'll be able to tell you that those numbers have changed significantly since Yasmin has come in. So we will provide that data for you.
Thank you so much.
Getting all the good news tonight, aren't you? Councillor Campbell.
Just a very quick anecdote. Several years ago, I was in the position of going through a carer's assessment, early help, all of that. And I cannot tell you how incredible the staff were at Medway Council. So helpful, so empathetic. They knew what to ask me before I knew what was going to happen. So I just want to say the statistics don't always reflect that, but when your staff do get to those assessments, I thought it was excellent. Quick question on the, the Medway Carers panel. So I understand the purpose of it is to kind of have a more joined up approach, everybody looking at how you can tackle problems. But is there no space there for maybe some actual service users, carers? Or is that not what this panel is for?
Yep. Okay. So the carers panel is because we were seeing a real increase in the number of people that needed support, carers support, but it was very inconsistent depending on the social worker or the OT or so on and so forth. So what we thought was, well, actually, we've got the experts, we've got carers first. So why don't we help them and ask them to come on board? So at the moment, we've got carers first, we've got kindy, our social work teams and so on. And then when the social worker comes and says, well, this is Mr. Smith, then actually they say, actually, we think we can deliver this better than social care. So that's what that's looking at. Actually, it's how can we deliver the best service? I think from the bringing people on board, that's when we look at our co-production board and how do we bring people in, and that would definitely need somebody from carers support there.
Councillor Finch.
Thanks. Can you help me understand, Jackie, how you measure whether early help actually reduces demand for long-term care?
Yep. Okay. So effectively, if somebody is referred into adult social care, we do a review and we look at is there something that can be done to support that person to mean that they know, we can do some short-term work that means they no longer need adult social care. So we do reablement work. We've had some really good success stories recently, and hopefully what we want is that person then can go and live their life. Might need support from the voluntary sector or so on and so forth. But we also look at there are people that by the time they've got to us, any form of prevention isn't going to make any difference because they need that care and support and they're going to have a statutory service. So it's very much based on a case-by-case basis. The other challenge we have is all the time we're doing that, all the time that we are doing the work, demographics increasing, people are getting older. So what we need to try and do is make sure that we are, I'm going to use the word netting it out effectively, because otherwise we're just going to continue to see that rise.
Is it more of a model then that you look for when getting some metrics out of the system?
Yeah, so I mean, we'll be able to say, so ultimately when we are doing an assessment, we have to look at the outcomes and what does that mean for a person. So actually, I don't know, I want to go out today and I've not been able to go out for 2 weeks. Our OTs work with them and then we can say, actually, that's happened and therefore, we've seen that they're safe and they're well, and that means we don't need to work with them anymore. So we can then look at actually what that success factor is and how does that work. There's other things as well around people that come out of hospital and how long do they stay out of hospital. If they stay out for 90 days, then actually that reablement has worked. So there's all sorts of pieces that we look at to determine how well the service is working. But as I say, there are lots of people that can't be reabled because they've reached a point where actually their health and social care needs mean they need statutory services.
Finally, Councillor Wiley, your question?
Yep. Two
mic's off.
Two questions, if you don't mind. Page 88. On 3.1, there's a whole list of numbers and percentages. At the very bottom line, support and less than 1% each to residential or nursing care. Now, as I say, lots of numbers there. I didn't quite understand the 1%, if you could explain that. And
Jackie, do you want to do that now before your second question?
What the numbers are saying, this is the number of people that we've been referred to. Effectively, then, this is how many people that we signpost that don't need care or support. Yeah. That paragraph basically says all of those numbers that come through, of all of those, only 1% went on to receive residential or nursing care. So that's all the work that the team are doing across the board.
But is that in a year? Because some of those people will come back, I assume, the next year and would then be in that 1%. Just trying to understand it, not... Yeah.
So that data was for a year. It was from July 24 to June 25. Yeah. Effectively, they may come back 6 months later because something's happened and then they'll need that care and support.
Second question, Councillor Wiley.
You are in a rush.
Not in a rush. I'm just trying to stick with democratic services, but it doesn't always work, I know, but I'm trying my best. Go on.
Right. 3.4. The increase, and you just mentioned demographics. Is there a model that tells us when the demographics will improve? And I know that will be years hence, but do we know when that might be?
So at the moment, our colleagues in public health do lots of work around what does demographic growth look like, and up to 2030, it's not showing any sign of a decline.
Okay, thank you.
Thank you, Councillor Wilding. Vice Chair.
I move that the committee notes the report. Further, we have requested data on the length of delay in making initial contact and the level of improvement to this metric.
Is that seconded, members? And agreed? Agreed, thank you. My voice is holding on just barely there now. Item 11, we got the CPM. Is that you, Jackie?
Yes, so as with other reports, I'll take the report as read, sorry, and I'm open to any questions.
Not as red. Yeah, we don't want red the colour. Okay. Councillor Goldwyn.
Thanks, Chair. Whilst it was very good, Jackie, to hear that the areas of concern that the CQC had are improving, we've got a lot of red there. So in a nutshell, for the chairman's benefit, what's the plan for, to get out of the red and into the amber and green?
So the plan is obviously a mix. It's not just adult social care. I'm sorry, Eilish, but there's reds in from public health perspective.
Yeah.
I think the key one that sits with us and we talk about a lot at committee is around the number of direct payments. And again, I keep saying that there's a huge amount of work that's going on there within the teams to increase that. Some of that does come down to people's choice. If somebody doesn't want a direct payment, we can't force them. So some of the indicators are always a challenge because there are people that would prefer to have home care and not go down the direct payment route. Some of the other areas in there around the MEC training, which is making every contact count, and that's working with our providers. We know that there was a challenge there. Some of that was due to staff turnover within home care agencies. But next time you see that, we'll see a shift there because there's been some movement already.
Thank you, Councillor Goldwyn. Councillor Wilding.
A quick question. Page 98, 4.2, the direction of traffic, is that mostly due to demographics again, or are there other reasons?
So 4.2, so that's across all of the performance indicators, not specifically adult social care. So I would need to have a look at that in more detail. It's the council plan, the whole council plan. So yeah, it's not specific, so I'd need to go away and have a look at that for you.
Thank you.
Is there anything particular do you want Jackie to come back on that, or?
Well, the direction of traffic's on the adult social care bits, because I may have picked the wrong page, but I think, yes, they are also going in the wrong direction. Thank you.
Very much, Councillor Wiley. Councillor Cook.
Yeah, I think, just very briefly, I think the one that jumped out on me is the MECC training, which I'm going to admit I had to just double check I knew what it meant. And I'm curious, with an employment matters hat on, around if there's training that our staff need that people can't get hold of, the comment there about the provider. So just a bit more on that, please. Thank you.
I think it'd probably be helpful to do a bit of a briefing note about making every contact count, if I'm honest, because it's quite long-winded. So it is around, it's care providers. So it isn't necessarily council staff. So I think actually it'd probably be quite a long-winded response. So if you're happy for me to do a briefing note, then I can do that and feed that back.
I'm happy if you do a briefing note. I think we're up to about 6 briefing notes this evening, but we're going to be a lot of reading. Good luck, Steph. Or Terry. Councillor Aircraft-Scott.
Just quickly, page 107, section 1.04, assistive technology and re-enablement. Thank you for that lovely evening. But are you keeping the evidence of the difference that these assisted technologies are making to empowering people and improving lives?
So from an adult social care perspective, as part of their assessment, we need to review that so that we can see what's happening and how that's impacting and how that's working. Sometimes actually it means that we do have very little involvement. We'll put in some assistive tech and then it's quite minimal. Kindy do from their perspective for people that are self-funding as well. So yes, we do check that's working.
Thank you, Chair.
It's a really good point anyway, but I think it was made pretty clearly by Jackie on that night, and it was a good evening for all members that attended. Obviously you can't beat the human touch as well. It's not all about the AI. on that. Vice Chair.
I move that the committee notes the progress of performance in Q3 as set out at Appendix 1 and the strategic risk summary set out at Appendix 2. We've requested a briefing note on the direction of travel for the adult social care elements of the report and a briefing note on MEC training.
Is that seconded, members? Is that agreed? Agreed. Thank you. Oh, it does. And then we're coming to items 12 and 13 for Dave, and I'll put an hour aside for these two items for you, Dave. I don't mind staying here till 11 now to hear you on this evening for you to go through these. So over to you, Dave.
It's your choice, Chair. So that's absolutely fine. Yes, I won't do an introduction for either paper. I'll take them as read in the interest of time. Happy to take questions as anyone has.
Questions on either one? Councillor Waddy?
A comment, I believe these are really out of date after the budget at council meeting, so no questions from me anyway.
That's happened before, isn't it? It sort of follows through and it doesn't catch up on our Q3 and the thing, yeah. Yeah. Any questions on the two papers for Dave? No?
What are we going to do without you, Dave? There's a question. We're going to miss you.
I know, I think before we hand over and before we do a decision, I think I need to say, before we make an agreement, that we do want to take this opportunity, Dave, to wish you all the very best. This is your last HAS meeting tonight, and we've made you wait. You can always come and just sit at the back there. You're more than welcome. And we know you're leaving Medway for pastures new, but you never know. We may meet again in time. You're not going that far, I know. So, but can I just say personally, on all the committees that I know I've seen you on, but especially this one, I just want to thank you for all your help and advice. You've really helped the committee in all ways. So thank you very much for that. And I think members will certainly agree with that. But we wish you all the best, Dave.
I'll just say, it was worth coming after all that for that one. That's fine. No, I appreciate the kind words. I mean, this is my favourite committee. Don't worry, Dan. Give no offence, Joe.
Well,
given my background with adult social care and the 19 years I've worked with Medway, I've been involved with adult social care from day one. So it's really, yeah, it's nice to be appreciated.
And you don't realise you have to buy everyone a drink after the meeting. But thank you very much, Dave, for that. But you will be missed, Dave. Thank you so much. Is that Vice Chair?
Okay, so on item 12, I move that the committee notes the results of the third round of capital budget monitoring for 2025-26 and the changes to the approved budget since round 2 as set out in section 5.1 of the report. And on item 13, I move the recommendations as set out at 1.1 to 1.5 of the report on page 143 of the agenda pack.
Is that seconded, members? Is that agreed? Agreed. Final item, Stephanie, work programme.
Right, nothing to add to the report, but Terry has asked me to let you know that she's looking to set up a member development session on dementia awareness. This will be widened to all members, but targeted for HAS members in particular, and she'll be in touch soon with more information.
Thank you. Councillor Whitey? More than welcome. Any questions for Steph? Oh, all that time. Vice Chair.
I move that we note the report and agree the work programme as set out at Appendix 1 to the report, subject to accepting the proposed changes outlined in italic text on Appendix 1.
Is that seconded? Is that agreed, members? Thank you very much for everyone, including the subs. You've been wonderful tonight. Thank you very much. Have a good evening. Thank you.